السلام الملكي. بسم الله الرحمن الرحيم. سعادة الأستاذ محمد بن سعود السماري، مدير عام فرع وزارة الموارد البشرية والتنمية الاجتماعية بالمنطقة الشرقية، راعي الحفل. سعادة مدير خدمات الأعصاب بتجمع الشرقية الصحي الدكتور زياد الثاني، الشريك العلمي. سعادة رئيس مجلس إدارة مجمع الأمير سلطان للتأهيل إيفاء، المهندس خالد بن عبد الله الزامل. السادة الأطباء والأخصائيين، حضورنا الكريم، السلام عليكم ورحمة الله وبركاته. في ظل ما يشهده الوطن من قفزات معرفية نوعية وإنجازات علمية تاريخية، حيث تقودنا فيه حكمة خادم الحرمين الشريفين الملك سلمان بن عبد العزيز آل سعود، وتسير بنا همة ولي عهده الأمير محمد بن سلمان بن عبد العزيز آل سعود، حفظهم الله وأدامهما ذخراً وعزاً. نرحب بكم في ملتقى إيفاء العلمي في دورته الثانية تحت عنوان اضطرابات النمو العصبي، التشخيص والتدخل المبكر، والذي ينظمه مجمع الأمير سلطان للتأهيل إيفاء، وبشراكة علمية مع تجمع الشرقية الصحي، وذلك في يومي الأربعاء والخميس الموافق 17 و18 من شهر ديسمبر لعام 2025، ويهدف إلى مناقشة أحدث المستجدات والمنهجيات في مجال النمو العصبي بمشاركة نخبة من الخبراء والأطباء والأخصائيين. وخير ما نبدأ به حفلنا آيات من الذكر الحكيم.
الله نور السماوات والأرض، مثل نوره كمشكاة فيها مصباح، المصباح في زجاجة، الزجاجة كأنها كوكب دري، يوقد من شجرة مباركة زيتونة لا شرقية ولا غربية، يكاد زيتها يضيء ولو لم تمسسه نار، نور على نور، نور على نور، يهدي الله لنوره من يشاء، ويضرب الله الأمثال للناس والله بكل شيء عليم.
الكلمة الآن للرئيس التنفيذي لمجمع الأمير سلطان للتأهيل إيفاء، الأستاذة رنا جميل طيبة.
السلام عليكم ورحمة الله وبركاته. سعادة الأستاذ محمد بن سعود السماري، مدير عام فرع وزارة الموارد البشرية والتنمية الاجتماعية بالمنطقة الشرقية، راعي الحفل. سعادة مدير خدمات الأعصاب بتجمع الشرقية الصحي الدكتور زياد الثاني، الشريك العلمي. سعادة رئيس مجلس إدارة مجمع الأمير سلطان للتأهيل المهندس خالد بن عبد الله الزامل. الأطباء الأخصائيون، ضيوف الملتقى، الحضور الكريم. باسم مجلس إدارة ومنسوبي مجمع الأمير سلطان للتأهيل إيفاء، أرحب بكم جميعاً في هذا الصرح المبارك، والذي يحمل في أروقته إرثاً يمتد لأكثر من 3 عقود، ما بين أثر بناه المؤسسون والداعمون وتفاني قدمته الكوادر المخلصة. في كل عام تأتي مناسبة اليوم العالمي لذوي الإعاقة، والتي نحرص فيها أن نقدم مساهمات مجتمعية تجسد قيمنا، ألا ومنها الإنسان أولاً. ويأتي الملتقى العلمي في دورته الثانية لعام 2025 تحت مسمى اضطرابات النمو العصبي، التشخيص والتدخل المبكر، وينطلق من 3 مرتكزات استراتيجية ليحقق 4 من أهداف العالمية للتنمية المستدامة، ويصب في 6 أهداف في رؤية مملكتنا الطموحة 2030. وفي ضوء ذلك فإن إيفاء اليوم تنظر برؤية وطن لتنشر العلم والمعرفة باستثمار كوادرنا الوطنية من نخبة الخبراء والمتخصصين في مجالات طب الأعصاب وطب النمو، الطب الجيني، الصحة النفسية، العلاج التأهيلي. واستناداً إلى الحاجة العلمية والمجتمعية الملموسة في هذه المرحلة، سيشهد الملتقى تسليط الضوء على التطورات الحديثة في تشخيص اضطرابات النمو العصبي والتدخلات المبنية على الأدلة وأهمية التكامل العلاجي، ودور الأسرة ومنظومة الرعاية متعددة التخصصات في رحلة نمو الطفل، وغيرها الكثير من المواضيع والاتجاهات العلمية ذات العلاقة. كما وقد حرص المنظمون على توفير أركان استشارية يقدم فيها الخبراء والمتخصصون التوجيه والدعم المباشر للمستفيدين، إضافة إلى توفير أجهزة الترجمة الفورية بهدف توسيع دائرة الاستفادة لدى مختلف الفئات. ويسعدنا من خلال مركز إيفاء الطبي أن نعلن عن مساهمتنا النوعية عن طريق تقديم خدمة الفحص التأهيلي المجاني لجميع الأسر في هذا الملتقى. وفي ضوء ذلك نستشعر مسؤوليتنا في مجمع الأمير سلطان للتأهيل إيفاء تجاه المجتمع في نشر المعرفة المستندة على الأدلة، ونواصل دورنا المحوري في التوعية والتثقيف على نطاق أوسع. ونرى أن هذا الملتقى امتداداً لدورنا المهني المتخصص، حيث أن منظومتنا التأهيلية الشاملة لا تكتمل إلا بالشراكات الفاعلة والبرامج النوعية. ويسعدنا هنا أن نعلن أننا في صدد إطلاق برنامج سيدر ليصبح نموذجاً وطنياً احترافياً يجمع بين التشخيص والتدخل المبكر ضمن منظومة تأهيلية طبية تربوية تستهدف الأسر والأطفال من عمر الميلاد وحتى عمر 6 سنوات، والذي سيتم إطلاقه بإذن الله في شهر يناير لعام 2026. كما يطيب لي في هذا المقام أن أتقدم بوافر الشكر والتقدير إلى راعي حفلنا وإلى الشريك العلمي لهذا الحدث، وإلى رعاة الملتقى الكرام، وإلى أعضاء اللجنة العلمية والمتحدثين من الأطباء والأخصائيين على ما سيقدمونه خلال يومين من خبرات تسهم في إثراء الجلسات العلمية. وأود أن أتقدم بخالص التقدير والثناء لفريق ملتقى إيفاء الذي عمل جاهداً منذ شهور للتحضير وإقامة هذا المشروع العلمي الكبير. ونسأل الله الذي لا إله إلا هو أن يكون هذا الملتقى محطة ملهمة تفتح آفاقاً نحو وعي أكبر وترتقي بجودة الحياة في الأسرة والمجتمع. والسلام عليكم ورحمة الله وبركاته.
يتفضل الآن سعادة الأستاذ محمد بن سعود السماري، مدير عام فرع وزارة الموارد البشرية والتنمية الاجتماعية بالمنطقة الشرقية، راعي حفلنا لهذا اليوم، لإلقاء كلمة بهذه المناسبة.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيد الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. أصحاب السعادة، الحضور الكرام، يسعدني أن أقف أمامكم اليوم في افتتاح ملتقى إيفاء العلمي تحت عنوان اضطرابات النمو العصبي، التشخيص والتدخل المبكر. هذا الحدث التوعوي المجتمعي الذي يعكس رؤية وطن جعل الإنسان محور التنمية، واعتنى بتمكين أفراده ورفع جودة الحياة وفتح الآفاق أمام المتخصصين وأسر الأطفال للوصول إلى المعرفة السليمة والممارسات المبنية على الأدلة. إن اضطرابات النمو العصبي ليست حالة صحية فحسب، بل هي مسار حياة يبدأ منذ لحظات الطفولة الأولى، وتمتد آثاره النفسية والاجتماعية والتعليمية إلى الأسرة والمجتمع بأسره. ولذلك فإن التعامل معها يحتاج إلى وعي مبكر وتشخيص دقيق وتكامل جهود بين القطاعات الصحية والتربوية والاجتماعية. وهذا اليوم يمثل نموذجاً حياً لهذا التكامل الذي تسعى إليه وزارة الموارد البشرية والتنمية الاجتماعية ضمن رؤيتها المستمرة لتمكين الأشخاص ذوي الإعاقة ودعم أسرهم وتعزيز منظومة الحماية والرعاية والتنمية. إن من أهم ما يميز هذا الملتقى أنه يجمع بين الخبرة العلمية المتخصصة من جهة وصوت الأسرة من جهة أخرى، ليقدم نموذجاً واقعياً لتفاعل المجتمع السعودي مع احتياجات الأطفال، وفهم مؤشرات الاضطرابات النمائية والتدخل في الوقت المناسب، في حين أن التدخل المبكر يحدث فارقاً كبيراً في قدرة الطفل على التعلم والتأقلم والنمو السليم، وهو ما ينسجم مع رؤية المملكة 2030 التي أولت الصحة والتعليم والرعاية الاجتماعية مكانة محورية. كما أود أن أؤكد أن وزارة الموارد البشرية والتنمية الاجتماعية تعمل باستمرار على تطوير السياسات والمبادرات التي ترفع مستوى الخدمات المقدمة للمستفيدين وتدعم المراكز والجمعيات المتخصصة، ومنها مجمع الأمير سلطان للتأهيل إيفاء، والذي أصبح اليوم واحداً من النماذج الوطنية الرائدة في التأهيل وجودة الخدمة والابتكار في برامج التدريب والعلاج والرعاية النهارية. وإن الشراكة العلمية التي نشهدها اليوم بين إيفاء وتجمع الشرقية الصحي تؤكد على أن التكامل بين القطاعات هو الطريق الأمثل لتحقيق الأثر المجتمعي الممتد. ولا يفوتني أن أتوجه بالشكر والتقدير لكل المتحدثين والمتخصصين الذين قدموا خبراتهم لخدمة مجتمعهم، كما أشكر الأسر على حضورهم وإدراكهم لأهمية هذه الملتقيات العلمية، وأثمن الجهود الكبيرة التي قام بها فريق مجمع الأمير سلطان للتأهيل إيفاء لتنظيم هذا الملتقى وإخراجه بصورة تليق بالمستفيدين والمجتمع والقطاع غير الربحي في المنطقة الشرقية. أسأل الله أن يبارك في الجهود، وأن يكتب لهذا الملتقى أثراً علمياً وتوعوياً يمتد إلى مستقبل أبنائنا، وأن يجعل نتائجه لبنة جديدة في مسيرة التمكين وجودة الخدمات في وطننا الغالي. والسلام عليكم ورحمة الله وبركاته.
الحضور الكريم، نترككم الآن مع الدكتورة رائدة البرادعي، استشاري طب أعصاب وصرع ونائب رئيس اللجنة العلمية في ملتقى إيفاء العلمي، فلتتفضل إلى المسرح.
السلام عليكم ورحمة الله وبركاته، وأسعد الله صباحكم بكل خير. الحمد لله والصلاة والسلام على أشرف الأنبياء سيدنا محمد وعلى آله وصحبه أجمعين. الحضور الكرام، في البداية أود أن أشكر جمعية إيفاء مجمع الأمير سلطان التأهيل وكل من قام على تنظيم هذه الفعالية، وأخص بالشكر الأستاذة رنا طيبة الرئيس التنفيذي لإيفاء وجميع من قام على هذه الفعالية. It's really my privilege to talk to you during this scientific meeting of neurological developmental disorder and diagnosis and early intervention. I'll speak to you regarding what's neurodevelopmental disorder and what's the child plasticity. Can I put the slides, please? Can you start, please, the slides? Okay. How can I move it? Okay, I will start my presentation with a case that we do see, unfortunately, on a daily basis. Yusuf is a 2-year-old boy brought by his mother to the neurologist because of delayed speech, poor attention. He had no words at the age of 24 months, minimal eye contact, repetitive lining of the toys, significant tantrum with change in routine. The mother said, I felt he slipped away from me. At assessment, he had high score on MCAT, delay in communication and social interaction, normal hearing test. He was diagnosed with autistic spectrum disorder. So early intervention started immediately. Speech therapy 3 times a week, behavioral therapy, sensory regulation, fine motor, parent coaching, mother trained to apply strategic at home. The family committed strongly despite the challenges. However, 6 months later, Yusuf started using 20 to 30 words, engaged in shape play, reduced tantrum, improve eye contact, and social connection. For the first time, Yusuf ran his father when returned from work. His father said tearfully, "This is the moment we have been praying for." The mother said, "We regained hope. He is not the child we worried about. He is the child we deemed on." So neurodevelopmental disorder is a group of conditions characterized by early onset difficulty, cognition, communication, behavioral, adaptive dysfunction, which include autistic spectrum disorder, attention deficit hyperactivity disorder, developmental delay, intellectual delay, speech and language disorder, and learning difficulties. Unfortunately, the incidence has been increasing steadily throughout the globe. This is probably due to improved awareness, diagnostic practice, evolving environmental and genetic factors. The autistic spectrum disorder account 1 to 2%. In Gulf region, it's much higher, and it reaches 1 every 36th child. Attention deficit hyperactivity disorder is 5 to 7% of school-aged children, and this data is compatible to the data we have in Saudi Arabia. Developmental delay and speech disorder is 15 to 17% of preschool children. These numbers are not abstract. They translate the thousands of children across the Eastern Province who require structured developmental surveillance and timely access to specialized care. These numbers remind us of one truth. This is not a rare issue. This is our children's, our families, our classrooms, and our future workforce. So here in Eastern Health cluster, in particular, demonstrated a leadership in certain integration care, multidisciplinary clinic, and community outreach. And during this 2030 vision, Alhamdulillah, the neurodevelopmental care is the heart of this vision, because when we support a child today, we strengthen a family, and when we strengthen families, we strengthen a nation. So why we need to have early intervention? Science tells us that the first 3 years of life, during this period, it's extraordinary brain plasticity where the children's brain is growing, building network, shaping behavior, laying the foundation of life learning, and during this time, synaptic connection from unprecedented rate, making the development brain highly responsible to structural therapeutic input. So this is really critical period to intervene with these children. So early intervention is when we diagnose early, when we intervene early, when we support parents early, we are not simply a training condition, but we are expanding children's potential. So evidence-based outcome of early intervention has shown, based on many scientific research, that it enhances language, improves cognitive, strengthens social engagement, reduces severity of behavioral illness, and these kids can be independent when they grow and when they become adults. And the evidence-based outcome of early intervention showed that 70% of children who had autistic spectrum disorder and start early intervention improve by age 3. Attention deficit hyperactivity disorder, early behavioral management combined with structured school support reduce long-term complication and improve academic trajectory. So whatever we spend for these kids, it's really worth it. So we need to work hard and start the early intervention. We have strategic opportunities for Eastern Health Cluster, which include implementation standardized developmental screening, establish integrated care pathway, and expand early intervention services, strengthening parent and community education, advanced research and rate registries, with the mission that every clinician, leader, educator, policymaker, parents hold a piece of this solution in order to make this patient benefit. Because every child deserves to be seen, every parent deserves to be supported, and every future deserves chance to shine. And the vision is every child is screened for neurodevelopmental disorder in the first year of life. Every parent has an access to early guidance support. Every school is equipped to understand accommodation neurodiversity. Every region has specialized center and profession, and every community embraces differences with pride, no, not a fear. This vision is not far, it's not impossible, it starts with us. So in conclusion, children with a neurodevelopmental disorder are not behind, they are on their own path. They do not need pity, they need opportunity. They don't need to be fixed. They need to be understood, supported, empowered. So they need to receive opportunity to reach to their fullest potential. Every child, regardless of ability, can grow, learn, contribute with dignity and pride. And when they surprise us, inspire us, and remind us that brilliance comes in many forms. Thank you.
نستأذن الآن راعي حفلنا لهذا اليوم سعادة الأستاذ محمد بن سعود السماري، مدير عام فرع وزارة الموارد البشرية والتنمية الاجتماعية بالمنطقة الشرقية، ورئيس مجلس إدارة مجمع الأمير السلطان للتأهيل إيفاء المهندس خالد عبد الله الزامل، بالصعود إلى منصة الحفل لتكريم الرعاة والمشاركين والمتحدثين. الشريك العلمي للملتقى تجمع الشرقية الصحي الدكتور زياد آل ثاني. شركة الخدمات الراقية الأستاذ صالح الحميدي رعاة الملتقى. شركة تحريز الأستاذ علي الناجي. شركة نابكو الوطنية الأستاذ جمال المعيبد. شركة فنون غالي الأستاذ أحمد غالي. شركة القصيبي للخدمات المحدودة الأستاذ عبد الرحمن القصيبي. مجموعة دان للفعاليات الأستاذ عبد الرحمن العنزي. فندق كيمبنسكي الأستاذ محمد المؤمن. شركة بجت لتأجير السيارات الأستاذ عبد الله الزهراني. شركة إيساد لحلول الموارد البشرية الأستاذة مجد القحطاني. شركة النسبة المختصة للتجارة ريشيو الأستاذ محمد الملحم. فرع هيئة الهلال الأحمر السعودي بالمنطقة الشرقية الأستاذ أيمن اليامي. اللجنة العلمية الدكتور محمد سي العربي. الدكتورة رائدة البرادعي. الدكتور فيصل القرشي. الدكتور تركي البطي. الدكتور عبد الله البحراني. المتحدثون والمشاركون: الدكتورة آيات الوحيد، الدكتورة دلال بوبشيت، الدكتورة زهرة الفرج، الدكتورة سارة سلسلة، الدكتور صالح الصالحي، الدكتور عبد العزيز التويجري، الدكتور عبد الله البرعي، الدكتور نايف الزهراني، الأستاذ عبد الوهاب الزهراني، الأستاذة هيلدا سجيني، الأستاذة الجوهر الشايجي، الأستاذة أسماء مطبقاني، الأستاذة أمنية عرب، الأستاذة آيات القصاب، المستشار رئيف شويري، الأستاذة غدير مطبقاني مدير مشروع الملتقى العلمي، باسم مجلس إدارة مجمع الأمير سلطان للتأهيل إيفاء، نتقدم بالشكر الجزيل لفرع وزارة الموارد البشرية والتنمية الاجتماعية بالمنطقة الشرقية، ونتشرف بأن نقدم لمدير عام فرع الوزارة سعادة الأستاذ محمد بن سعود السماري درعاً تذكارياً بهذه المناسبة. حضورنا الكريم، بهذا نختتم حفل الافتتاح ونعلن عن بدء أعمال الملتقى العلمي الثاني لعام 2025. Ladies and gentlemen, it is with great pleasure that we renew our warm welcome to you at IFA Scientific Forum. This year, we gather under the theme Neurological Developmental Disorders, Diagnosis and Early Intervention. Here, experts and specialists come together, joined by the valued families of the Eastern Province, to raise awareness and clarify misconception and support families in the journey of their child's growth. For your convenience, simultaneous interpretation devices are available through our organizational committees. This forum brings together 8 scientific sessions and 23 distinguished speakers, from experts, physicians, and specialists. These sessions are scheduled over 2 days. In addition, we have prepared 6 consultation stations to serve the families attending this forum, along with a special track for multidisciplinary initial rehabilitation assessment offered at IFA Medical Center. The scientific session schedules will be displayed on the forum's official website, internal screens, signage, and across our social media accounts. We kindly remind you of the importance of maintaining a calm atmosphere during the scientific sessions by ensuring the mobile phone are set on the silence mode. We are honored to host you during the inter-session breaks with refreshment served in the hospitality area to the left of the main entrance of the center. For women, restrooms and the prayer area are located on the right side of the stage. And for men, restrooms are situated outside the hall on the right-hand side, and the prayer area in the mosque outside this building. Please note that emergency exits are on the right side of the stage, at the beginning and the end of the hall. And they are clearly marked with a bright green color. If you require any assistance, the forum's organizational committees are always at your service. Once again, we extend our warm welcome to you all. And now, we will move on to the first scientific session of the forum, focused on emerging research and diagnostic advances. Joining us on the panel are Dr. Ayat Al-Wahid, Dr. Dalal Bubshet, and Dr. Zahra Al-Faraj. The session will be moderated by Dr. Abdullah Al-Bahrani, a pediatric neurology consultant at the Maternity and Children's Hospital in Dammam, Eastern Health Cluster. Doctors, the floor is yours.
Bismillah ar-Rahman ar-Rahim. It's my pleasure to moderate the first session. The first session is about emerging research and diagnostic advances. This session will highlight a recent development in neurodevelopmental disorders with a focus on fundamental concepts, genetic and neurological biomarker, and advance in early screening and diagnostic tools. Before we begin, there will be an SMS with a dedicated link for questions, which will be answered at the end of this session. And there will be also a question and answer at the end. The first speaker will be Dr. Ayat Al-Wahid. She is a developmental pediatric consultant and program director of the Development Pediatric Fellowship in King Abdullah bin Abdul Aziz University Hospital, Prince Noura bint Abdurrahman University. She will give us a talk about fundamental concept in neurodevelopmental disorder. Welcome, Dr. Ayat.
Thank you very much, and it's my pleasure to be part of this scientific symposium. So, do I have? Can I have the slides, please? So over the coming few minutes, I'll be talking about the fundamental concepts in neurodevelopmental disorders. Actually, there are a lot of concepts that we need to cover throughout this session, but because of the limit of time, بس ما أشوفهم أنا السلايد ما راح أشوفهم يعني. راح أرجع الحين. لا أحتاج الأول السلايد الأول. Okay. So I'll be focusing more on the most important or most frequently required or most frequently missed concepts related to neurodevelopmental disorders. So first, what are the developmental or neurodevelopmental disorders? So those are an early years impairment that affect the child's ability to develop, learn, and function in daily life. So the impairment or the significant impact on personal, social, and academic or occupational functioning is a requirement for any child to be diagnosed with a neurodevelopmental disorder. And the impact or the delays can affect any of the major developmental domains, including cognitive skills, speech, language skills, social skills, motor ability, behavioral regulation, adaptive functioning, or even play skills. It doesn't move. Okay, so there are some important core principles when you meet with the parents or when you start an assessment of a child who's presenting with a neurodevelopmental concerns. First thing you have to do, you have to listen to the parent. You have to listen to their concern. Parent concern is a valid and powerful screening tool. So research has consistently proved that parent worries or concern are one of the important tools that usually discover children who need a further developmental assessment. So never dismiss a parent worry or a concern. You have to think developmentally, which means you have to focus on understanding the child developmental pattern. You don't have to jump to a conclusion. You have to map their strengths and challenges before you reach a specific diagnosis. And you have to ask the right questions. The most important question you need to address or to ask are what this child can do, what limit his ability to participate in daily life and learning or in or relationships. Because these questions will usually guide a meaningful intervention, not only will give the child a diagnostic label. You have to use the diagnosis as a tool. So the diagnosis is not the aim or the goal, but it's the tool to access the services or the intervention, because our ultimate goal is to improve the child's quality of life. You have to act early. So early intervention does not require, say, a diagnostic certainty. Whenever you discover the concern, you have to start your intervention right away so you don't miss the critical and sensitive area for the developmental period. And we always say, التدخل المبكر يصنع الفرق. So we have always to focus on the early intervention. And when you meet with the parent, you need really to clarify their concern, like what brought them to your clinic, why they are here, what they are worried about, because this will help you to focus your assessment. So you will direct their concern as a priority instead of going over incidental finding or other thing you discover in the clinic. You have to identify the primary concern. Which domains is affected more? It is the communication, the behavior, the motor skills, or the social participation. And the other important things, where the problem most be visible. Is it at school or at home? Is it in daily life or in communication? And that also will guide the urgency and the intervention pathway. You have to look and to find out the developmental profile. It's not only a developmental checklist that you go through it, but it's a developmental profile. You have to see if there is any asynchrony between different domains, if there is a plateau or regression of the developmental skills. You have really to identify what the skills that the child have versus how he can or she can use these skills functionally on everyday life. Context matters, so you will never assess or diagnose a child in isolation. Family dynamics and stress are really important, like the parent mental health issues, their financial burden, sibling relationship, what changes has happened in the family. All these have a great impact on the child development and trajectory. Cultural expectations, because what make a concern in one culture may be not a concern in another culture. Discipline strategies, communication style and language exposure, all these also affect the developmental trajectory. School support, like how many, the classroom size, what's the student-teacher ratios, what support, what special services available, all this will shape and will help in your diagnosis and intervention as well. Exposure to trauma, neglect, or environmental deprivation can either present in a similar way to neurodevelopmental or disorder or can exacerbate the developmental issues. And then, of course, the medical history, if there is any chronic illnesses, if there is any metabolic, genetic, or sensory issues, all these factors should be considered during your assessment, because we all know that same child same child in a different context will present with a different outcome. So context really matter. Observation in the clinic or during your assessment. It's a really valuable tool during your assessment. So there are a lot of things that can be observed and assessed by just watching the child in your clinic. Even before touching or interacting with the child. So those are some of the examples, they are not all, but one of the important things you can observe, like the child-parent relationship, the child interest and the way of initiating or responding to social interactions, their non-verbal skills or the non-verbal communication ways, like how they give the eye contact, do they use any gestures, do they understand gestures, do they express different facial expressions or not, their play style, their flexibility, their behavior, if there is any stereotype or sensory behavior. So their motor, their speak and language skills. So all these information you will gather only by watching the child in the clinic after you prepare your setup. So you will have to prepare your office or your clinic with different tools. You will have to prepare the way it's set up, where you sit and where the child and family sits, and then you will gain a really valuable information. After the observation, you will have, or sometimes you will need to do what we call it a standardized assessment tool. So you have to decide what is the aim of your tool, of the tool you are using. Is it for screening or diagnosis? What was the referral question? What do you want to reach? What you are looking for before you choose your tool? Screening tool is not a diagnostic tool. So if a screening tool is positive, this will mean that this child will need a further assessment. And if it's negative, this does not mean that the child has nothing, especially if the parent concern is persistent and the effect or the impact and function is still there or it's obvious. And then the context. So when you interpret the standardized assessment, you have to look to the context, the child condition, the child language, some cultural issues, and if the result of the standardized assessment does not match your clinical impression, you have to trust the clinical judgment. Don't depend on the standardized tool. So that was a major or a principal concept related to all developmental disorder. And now I'll try to focus a little bit on some condition or disorder specific concepts. And I'll start with the practical points related to autism spectrum disorder. So when it comes to autism, we always, or the aim, or the core of our assessment will be the communication, the social communication skills. So it's not the speech, because we know a lot of children with autism, they have a variety of vocabulary, but the issue is how they use this language in a social way. They struggle usually with the social use, with the back and forth conversation. And then when we look at the quality of interactions, we have to look specifically for the quality, not the number of interactions. So it's not, does the child give an eye contact or not? It's how this eye contact is, the quality of eye contact. Is it modulated with their verbal output? Is it long enough to finish the social interaction or not? So on and so forth. Play is really important, especially when it comes to younger kids. So it's a big part of our assessment is the play, like the type of play. Does the child play repetitive or functional or symbolic play or pretend or imaginary play? Are they flexible to integrate other people in their play? Is there any repetitive play? And then we look for the other behaviors like sensory and stereotype behaviors. There is an so it's really important to compare the skill to the developmental age, not to the chronological age when we assess children. And one of the things that it's really important to clarify and explain to the parent that the diagnosis of autism and most actually of the developmental disorder is a clinical diagnosis. So it means it depends on your clinical observation and the information you gather from the family and other caregiver. So there is no blood test, there is no images that can diagnose a child with autism. So that's a really important concept to explain to the family so you can meet their expectations when they come to your practice or your clinic. And then severity of autism does not always correlate with the intelligence or with the intellectual ability. We know that there are children who are diagnosed with autism who need a substantial support, but still their intellectual ability is average or above average. So those two conditions can coexist together. Each condition have a separate diagnostic criteria, but they do not omit each other's. And language delay doesn't always mean autism. So again, the autism and language delay can coexist together, but they can occur independent of each other. And then the most important is the early intervention, even before the diagnostic certainty. If you have a concern, refer your child to receive the required services. ADHD, that's another very common neurodevelopmental disorder we face in the clinic. So we have to think beyond hyperactivity because ADHD, it's usually an executive function disorder where it affects the working memory, the cognitive flexibility, planning, organization, and hyperactivity is only one of the presenting symptoms. And unfortunately, there are a lot of children, especially girls, they are not diagnosed because they don't present with the stereotypical presentation, which is the hyperactivity. And actually, those who have only the inattention often will label as a lazy and that they need to work for their full potential and they will not be diagnosed with the disorder. Another important thing you should consider when you are assessing a child with ADHD, always look for a comorbidity because ADHD can comorbid with a lot of conditions. Those are some of the conditions that they can coexist with ADHD. There are a lot of sleep issues, anxiety, learning difficulties, ODD, autism, developmental coordination disorder, tics and language disorders.
3 minutes.
Okay, when you look at ADHD, you need to remember that it's a developmental, not a situational condition. When a situational concerns around hyperactivity or inattention, you need to think about other things. Symptoms should present in a multiple setting, and it should impair the child function. And medication, it's one of the treatment or intervention modalities, but there are others like behavioral modifications. When it comes to intellectual disability, you have really to think of the adaptive and daily living skills. It's not only about IQ, because IQ will give you the cognitive potential of the child, but the adaptive functioning will tell you how much this child can function in everyday activity. A learning disability, one or the important hallmark of the learning disability, that the child will present with a normal cognitive ability, but with this academic struggles, inconsistency in their profile. And you will need a comprehensive educational assessment plus the psychoeducational testing. Global developmental delays. So that's one of the most common labels we give to children, but you have to remember that global developmental delays should be given to children younger than 5 years of age when they present with 2 or more significant developmental delay, and it's a descriptive term, so it describes the current delay of the child. It should be re-evaluated and reassessed, because children usually either they will catch up or they will get another diagnosis with time. Again, early intervention is a priority. And then I will end with the cerebral palsy, because we tend not to talk a lot about neuromotor disorder. So cerebral palsy is a permanent developmental disorder that happens when a child exposed, or the developing brain of a child exposed to a non-progressive disturbance. And it has a lot of comorbid condition. It's really important, again, to focus on how much the child is participating in the everyday activity, more than focusing on the spasticity or how much the tone is affected. And we have some tools that can help us when we assess the function of the child. One of the important tools is GMFCS. This tool is a 5-scale or 5-level classifications. It focuses on the gross motor ability of the child. So level 1, when the child only struggles with some balance and articulation issues, and level 5, when the child is a wheelchair bound, which require truncal support. Another tool is called MAX. Again, it's a 5-level classifications, and it focuses on the fine motor ability of the child, how much they can use their hands, with the same concept, level 1 with a minimal impairment, and level 5 when it's severe impairment. And the third tool is the CFCS, and it focuses on the communication ability of the child. Again, 5 levels. Level 1 is the near normal, and the 5 is the most significantly affected. When it comes to neurodevelopmental disorder, the comorbidity is the rule, not the exception. So please don't forget to assess for comorbidities. Intervention. It's really matter to start early. Intensive intervention. It has to be function focused and family centered. It goes with the family values, family need, and family condition. School collaboration is really important. Your goal need to be a clear, measurable goals with a regular review and adjustment. Families, this is the last slide. So family is really important. Family, they need us beyond labeling and diagnosis. They need us to act or to behave like a human. They want a clear explanation of their child condition. They want a hope, but without false promises. And then they need a guidance and a long-term partnership, because that's a lifelong condition that they need someone to help through. That's it. Thank you very much. And if you have further questions or you needed to reach out, you can find me at these social media platforms.
Thank you very much, Dr. Ayat, for elaborating in the fundamental concepts of neurodevelopmental disorder. I would like to welcome our next speaker, Dr. Dalal Boubshait. She is a senior consultant pediatrician and a clinical genetist at King Fahd University Hospital and associated professor at Imam Abdurrahman bin Faisal University. She also head of Saudi Society of Medical Genetics in Eastern Province. She will give us a talk about genetic and neurological biomarker across neurodevelopmental disorder. Welcome, Dr. Dalal.
Assalamu alaikum wa rahmatullah. Thank you for the introduction, and I would like also to thank the organizer for inviting me today. Can we have please the slides? So, starting with NDDs, it's a complex and heterogeneous disorder. So, Dr. Ayat and Dr. Raida ahead of me, they were talking about and highlighting about the definitions. So, it's a complex and heterogeneous disorders that affect the growth, development of the brain, and associated with impairment, cognition, motor, communication, and adaptive behaviors. So we know that they are complex and heterogeneous. Knowing the pathophysiology of such disorder is still difficult to the scientists. So knowing biomarkers of such disorder is also difficult and is broad. So to be clear, it's very challenging to have biomarker for such disorder. And having a clinical assessment and clinical diagnosis is most important than having some lab works that's done for those patients. So early intervention in such cases is the main target and goal in diagnosing such cases. So I will be highlighting about what's in the literature regarding these cases. So we know that it's global, and the global developmental delay and intellectual disability has been estimated to be 1 in 3%. And also NDDs in general are the most common chronic medical condition with a combined prevalence of 17%. So previous systematic reviews, meta-analysis looking into evidence of biomarkers, still there is no evidence of clinical used biomarkers that can be used in neurodevelopmental disorders. So there is a potential for treatment, but still biomarkers are not clinically used. So for the sake of time, I'll be concentrating on biomarkers in autism. We know that there is a global trend of increased rate of prevalence of autism and in general neurodevelopmental disorders. And this can be linked to a lot of factors. It can be environmental, genetic factor. It can be related to more awareness, more diagnostic tools, different definitions and diagnostic criteria. So the trend is up, and we need to know how we can deal and pick up these patients early. So the global prevalence of autism is reaching 1%, and different papers 0.2 to 3%. And there is a gender differences with male prominence, but also this is narrowed over the recent years. There is regional differences, but I think still the statistic is not covering the full number, and it's underestimated. So 40% of individuals with autism with complex phenotypic presentation will have genetic syndrome and chromosomal abnormalities. And this is a target for us in a clinical practice. When we assess a patient with autism, we need to look to the comorbidities, if there's any signs of dysmorphic features, if the baby is syndromic, or any signs of inborn error of metabolism. And the family pedigree is also very important to know if there is a family history of specific disorders pointing to autism or related disorders. So heritability have been studied in cases of autism, and it was mainly in the twins. So in monozygote twins who have the same genetic background, the prevalence of or the risk of autism was higher and related to dizygote twins. So that means there is a genetic factor. Still, there is some environmental factor, but because it's not 100% in monozygote twins, that means it's not like monogenic disorders. So the genetic defect in autism can be related to the testing or the tier indicated in such cases. So we know that in the first tier we will go for microarray or FMR1 gene if there is any suspicion, and then we go further with whole exome sequencing. So the focus initially was to look into chromosomal imbalance, deletion, duplications, any monogenic disorders, or risk factors. And now we're talking about epigenetic and not the genes themselves, the defect in the gene themselves, but the defect in the control of those genes. So methylation and epigenetic also have a role in such disorders. Early on, we're talking about sorry. I don't know how can I go back, yeah. So early on, we're focusing on monogenic disorder like Fragile X, tuberous sclerosis, Rett syndrome, on specific genes. Now, with the advent of whole exome sequencing and whole genome sequencing, we are looking into different genetic variation, and the GWAS testing of a larger population with autism and controls have showed us SNPs that may be related into genetics. So 80% of individuals with autism don't have a clearly identified single gene mutation, and this is very important when we counsel the family. So the genetic testing is not the solution, and it will not always give us the answer to their questions. What caused the illness for my child? It's not the genetics that will solve the issues in most of the cases, as you can see. So we are looking into multifactorial inheritance, and different studies have covered the environmental factors in different aspects, even when the fetus is in utero, and the exposure of the mother to different illnesses, or exposure to some medications, steroids, teratogens. All of this may change the environment around the baby and maybe can be a risk. So all of this is proposed and there, and some studies and different study as this study looking at the maternal gestational diabetes, and they measured the cord blood methylation and found to be low in cases with gestational diabetes associated later on with autism. So autism biomarkers are still not there, and there is urgency to find those biomarkers for the purpose of early detection and to see the response to treatment or intervention in such cases. So the absence of specific biomarker poses a significant obstacle to early detection and targeted therapy, but many promising biomarkers have been developed in autism. So if you can see, in the last decade, there is a trend into publication and journals attraction toward testing different biomarkers in cases not only in autism, also in neurodevelopmental disorders. The biomarkers is divided into the biological biomarkers like cytokines, gene expression profile, microRNAs, proteomics, metabolomics, intestinal flora, or it's digital biomarkers, which are neuroimaging classifiers, EEG, eye tracking, and behavioral analysis. Talking about the genetic biomarker, still we did not reach, so no genomic biomarker has yet been validated for clinical use in autism, but it's divided into DNA-related biomarkers or RNA-related biomarkers, and there is a big talk on microRNAs. So microRNAs are short non-coding RNAs that are produced inside the nucleus, and their function exactly is to control other genes. So they can control multiple genes rather than one gene, and here we'll be talking about more about epigenetic mechanism and the control gene. So when we see the genome may be normal, there is no defect, but the control of this genome is affected. So microRNA are heavily involved, and it's proven that they are heavily involved in neuronal plasticity, neuronal development, dysregulation, generates diverse neurological alterations such as autism. So it was differently studied. This is a recent recent systematic review, went over, studied microRNAs, and there is a promising microRNAs that can be detected in the serum or in the saliva of children with autism. So the microRNAs are highlighted in yellow. The most promising microRNA is the Okay, the microRNA for 451, and this microRNA can be detected in the serum or saliva of children with autism, and it's the most promising microRNA, and can be used for early detection of such cases. So they are not looking into early diagnosis and the screening of children. They are looking also to children just born and the indication of newborn screening for such cases. So even there is some studies in this regard. Here they measured the transcript level of 4 genes, and in a case control umbilical cord blood, and they found it was studied on around 2,600 kids. 40% had autism, and they had alteration in the transcript level with a high risk of autism. Still, this study needs validation. So also they are using the genetic biomarkers in clinical trials and intervention. So oxytocin-based intervention, we're looking into some genes like OXDR SNPs that will tell us if the patient can be responsive to self-medication. So the role of pharmacogenetics and individualizing the treatment to different cases and in personalized medicine, I think it's also will be there in autism in the near future.
3 minutes.
So going into the digital biomarkers, there is the known abnormalities have been seen in children with autism by neuroimaging and MRIs, and they suggested different types of neuroimaging such as the diffusion tensor, functional MRIs, PETs, and MRI scan, specifically the last in cases of inborn error of metabolism and mitochondrial dysfunction. So the functional MRI, it's a non-invasive technique and widely reported a significant change in children with autism. And multi-site testing functional data set has been used to develop tools for early diagnosis and assessment of cases with autism and to subtype them and to assess their severity. Also, EEG have been a promising tool in cases of autism. Here, they evaluated the brain waves changes in autism, and they found during different tasks given for the child, they found that the neuronal response to face could serve as a promising biomarker for autism diagnosis. So EEG also have been reported to have changes in the frontal and temporal parietal region at 3 months and can predict symptoms at 18 months. Children with autism also received social skill intervention, showed enhanced brain region connectivity, and can be used to monitor the effectiveness of any interventions. So in conclusion, MRI and EEG appear promising for early pre-symptomatic identification of autism. Not only this, also for monitoring of disease progression after interventions. Genetic biomarkers face challenges in clinical practice, and it's difficult to apply because of the complexity and heterogeneity of autism. Tackling neurodevelopmental disorder as a multifaceted global health challenge requires a comprehensive approach combining research, environmental influence, and emerging diagnostic and therapeutic technology. And the important message to say, we still don't have specific biomarker for such disorders. We are depending totally on a clinical practice and clinical evaluation and clinical suspicion. So increased awareness of such cases is highly important. But maybe in the near future, we will have different tools and validated tools that can be used to diagnose not only autism, other neurodevelopmental disorders. Thank you.
Thank you, Dr. Adalal, for your elaborations on the diagnostic tools and the neurological biomarkers and genetic testing in autism. Our next speaker, Dr. Zahra Al-Farraj, she is a developmental pediatric consultant and head of the Development and Behavioral Pediatric Center at King Salman Hospital in Riyadh. She pursued her subspecialty fellowship training in development and behavioral pediatric in Ontario, Canada. She will give us a talk about advances in early screening and diagnostic tool. Welcome, Dr. Zahra.
Yes. I will try. I'm going to thank the scientific committee for inviting me to this symposium to present to you about advances in early diagnosis. I'm going to specifically talk about MCHAT and RITA-T and some advances in neuroimaging that we need to order it for patients diagnosed with intellectual disability or neurodevelopmental disorder. So you're going to hear, I need somebody to share the slide so we can start our presentation, please. Okay. So I think I'm going to skip also multiple of slides. This is only to tell you about what is autism spectrum disorder. That it's a neurodevelopmental disorder that affects the places of controlling the speech, language, and communication and the repetitive movement. And sometimes it can be, the signs and symptoms can appear even as early as 6 months of age. So it's very important to have an idea about the DSM-5 criteria on diagnosis autism because it is the base of multiple of tools for diagnosis and the screening. And sometimes if you do the tool for screening, it will help you also how to ask the questions to prove that symptoms and signs is there or no. Okay, and what is the point of any screener or doing the screening test? The idea of it, you're going to hear it multiple of times here in this symposium. Early diagnosis and early intervention is making difference. And you can see here the severity of the autism, for example. It is mild, moderate, and severe. It depends on their needs for the intervention that they will need and how we can include them in the society and in the school. So what is our goal is to shift the patients or the neurodevelopmental disorder from the severe to moderate to mild. So we have a higher function individuals in the society. And that's why there is a Qarar Sami for an early screening program in Saudi Arabia for autism. The idea of it to make an early diagnosis to get the early intervention as much as we can. As we can see, this is the idea of the early intervention to be higher function individuals. There is lag between the remote and the shifting of the slides, so be patient with me. Okay, and this is just to give you an idea about the prevalence of autism. This is in US. And it was, just you can see, dramatical increasing in number from 1 to 150, and now it is 101 every 36 years. Just imagine, in every class, there is one autistic child on it. So it is that much, because of more diagnosing people, there will be more and more. So, however, on the other hand of that, the more diagnosis we do, the more screening we do, the more waiting time to get the diagnosis. And this is the problem with screening level 1. There will be a lot of people waiting to get the diagnosis and the intervention. And that's why later on I'm going to speak about the RETA-T, which is the level 2 of screening, just to short the timing for the get the diagnosis and the intervention. This is the newest. I think we are going there with this too. And this is a very important symptoms you have to ask it about the child's ability to point or to respond to the thing that you are pointing to. For example, if you ask the child, look, here, what is this? He will join that attention and look at that object that you are pointing to, or the opposite, that child will do it to ask you to look to something that he is pointing to. It's very important, these symptoms, because it is very important. It's like a landmark of autism, but not necessarily. But it's very important to know this because you're going to ask it in the clinic, especially if the parent, they have concern. And there is some also, you're going to see in the MChat and the RETA-T, they focus, there's multiple questions regarding joint attention and these things. So who's doing the screen? The one who's doing the screening tool, usually in the primary health care, as we did in our national Saudi program for screening for autism. We are doing it in the primary health care. We train multiple of family physicians and primary physicians how to do the MChat. And then even the pediatrician, we train them to do that. So it either in the primary health care or in a pediatrician will baby clinic. And here is just a chart to show you. The parent will come to the clinic, and then you will give them the tool, MChat, or what is most common is the MChat, and then they will fill it. You're going to see the screen is negative, and there is no concern. As Dr. Ayat, you have to listen for the parents, because sometimes if there is a concern, you will go for the next one. So if there is negative and there's no concern, so no, you're gonna just rescreen again in the next visit. If there is a positive and you have to do an immediate intervention and refer for a diagnosis so he can get the proper intervention. This is for the screening in the primary healthcare setting. And here we have what the pediatrician role also is not only to do the screening. You have to have an idea about the DSM-5 criteria, and you have to have about how to observe some of the symptoms and signs in the clinic. And you have to do the autism screening at the age of 18 and 24 months, and we will refer for the intervention according to what you find in your clinic. And this is also an American Academy of Pediatric flowchart to share with you if the patient come for the visit. And there is a specific questions you will ask the parent before doing any screening, because these concerns is really important to listen to them. If the sibling with ACD, there is a red flag, is there is a parental concern or other caregiver concern, or the pediatrician himself, he has a concern. So you're gonna score it. If he scored, this is the 4 questions. If he scored 2+, then you will go for early referrals for the intervention and the diagnosis. If he is a score 1, so it's in a gray zone, so you have, it depends on the age. If he is an 18 months, he is for a screening, so you will do an MChat, and then you will see what is the screening, is a positive or negative, and you will act accordingly. We're gonna speak that later on when we speak about the MChat. Just this is a basic, just to have information about how we choose the screening tool. We are depending on these screening test, how strong it is in sensitivity, specificity, positive predictive value, and the negative predictive value. The higher they are, the stronger the test. Okay, and most of the time, worldwide, we are using the MChat. It's the tool, international tool, translated to multiple languages, and it's you can download it from the website, and it's very, very easy to be applied. Using the MChat, and you're gonna talk more in details about what is MChat and So this is the website you can go through and upload the MChat. There is in multiple languages, even in the Arabic one, it is translated and validated. Validated between the age of 18 months to 13 months. But in some studies, they extended that to be from 16 months to be 48 months. So, and you can see it's only 20 questions and yes or no questions. So it's very easy. You can give it to the parents in the waiting area, fill it before going to your clinic, and then you will score it. However, how to score it? It is, when it is a low risk score, is 0 to 2, there is no concern and there is nothing to do, and only you're gonna rescreen at 24 months of age. If it is a score between 3 to 7, that means he's a medium risk, and there is a follow-up sheet with the MChat. There's more questions to be asked to make sure that the question that he's answered, which was positive, to make sure it was really positive, not a falsely positive, to make sure he will need a referral, or you can rebook for assessment again. For the high risk, if he scored more than 8 in the 20 questions, this is for sure you're going to refer for early intervention and diagnosis program. And here the problem with the MChat. It has a low positive predictive value for autism, but higher predictive value for developmental delay. And that's why when you give the news for the parent for the result of the MChat, you have to be very careful. You're not going to say he's at a high risk for autism and that's it. No, he's at high risk for autism or developmental delay. This is not a highly sensitive tool for autism, but it's very, for sure there will be highly false positive cases will be positive in the MChat. And this is what screen is about. You don't want to miss any kind of child, okay? And this, because of, you see, the lower protective value of the MChat to screen for autism, then they found another screen tool, which is RETA-T. It is very important tool because it is an interactive now. It is not about a parent, they will fill a chart or yes or no. It's about you, how you are interacting with that child, and you're gonna score that with a higher predictive value and higher sensitivity. So only here, the MChat, actually, I thought that there will be a time to explain to you how to score it, but unfortunately, there will be no time, I think. So I'm gonna skip just to show you the chart itself. This is by English, and this is by the Arabic language. And this is the scores and how you interrupt the score with the parents. And this is the follow-up scoring sheet. And this is the follow-up scoring sheet for the Arabic version. And here is the RETA-T. RETA-T, it's, as I said, is an interactive tool between you and the child. And the test is reliable also from 18 to 36 months. And now it's under study to extend that for more, up to 5 years, but still is under study. I'm a RETA-T trainer, certified trainer, and one of the questions was during training, we asked can we apply it for a developmental delay? If the child, developmental age between 18 to 36, can we apply it to? Yes, we can apply it between, if he is developmentally between 18 and 36 months. And here it's about a 9 to 10 interactive process, and we don't need any verbal language from that child to interact actually in that time. So it's we know why it started at 18 months, because some of them maybe not verbal at that time because they have developmental delay or autism. And when you score it, if it is below 12, that means he's a low risk for ASD. If it's 12 to 16, it's a medium risk. And if it is more than 16, very likely to be associated with ASD. And I will tell you why they developed this kind of tool, because as we can see, the more screening you do, the more patients will wait for diagnosis. And sometimes you can pick up the child as early as 1 year, but because he is waiting 3 years to get the diagnosis, he will lose the neuroplasticity, as Dr. Raida said, the golden time to get the intervention in the first fifth years of life. So it's very critical this age to get the early diagnosis. And this is the RITA-T activities, about 10 activities. It's all interactive between you and the child to see how he interact, and you will score it. And this is the sheet, how to score the sheet, and you will put at the end if you have any observation in relation to hyperactivity and these things. So this is the main goal of it, to find the medium risk, low risk, and high risk. And you can see in the high risk here, they give the right for the pediatrician to give the autism diagnosis without refer him to subspecialized person like a developmental behavior pediatric or child and adolescent psychiatrist, to give the diagnosis as early, and he will get the intervention as soon as possible. However, in the medium risk, who is in the gray zone, they will need actually to wait to get the diagnosis because they are tricky. They didn't get it positive in the RITA-T, it could be not a autism. So they can start intervention actually, but no need for give the autism, a rush for get the diagnosis of autism at that time. This is how to show you how it is highly sensitive and high protective value of RITA-T and diagnosis as a screener for autism. And you can see this is a sensitivity 0.98 to 0.82, and the specificity also is high, and the positive protective value is high too. And also it is validated to multiple language. It's validated to Arabic, but still not for training yet. So we trained in English, and what we apply it in Arabic actually. So this is the website, just let me back. This is a website, you can be trained online, 3 hours of training, and you can get the certificate, and you can apply RITA-T, and you can buy the kit from Kennedy Greger Institute website. Now, with the final subject that I'm going to talk about is about the neuroimaging. In the clinic, most of the time, the parent will look for an answers. What caused the autism? Is it genetics? It is something happened in the brain. Is it something we can do to reverse this kind of things? You have to put in your mind, anything you're gonna test it or do an imaging for that baby, you have to answer multiple questions. I'm gonna add anything if I do an MRI brain, or it's not gonna add anything. Add the thing, it means, can I do a treatment or management to reverse the disease itself? You get that? So it is very important to know, I'm gonna do it. Okay, what's gonna help me now? It's gonna help to have an answer to the parents or to help the child with giving the treatment. So here, this is the American Academy of Pediatrics to show you that if there is a concern of global development delay and intellectual disability, they wrote including MRI brain, hearing and vision test for any child with diagnosis of intellectual disability. It's not like that. Actually, there is a clear indication, not every child will diagnose a neurodevelopmental disorder, you need to do an MRI brain. If you do that, they will be awaiting people for 3 years to get that MRI brain, and I didn't know what is the benefit of that. So here is the indication for a neuroimaging for a neurodevelopmental disorder. If the child with global developmental delay or intellectual disability with abnormal head circumference, either micro or macro megaly, if there is a focal neurological sign like a seizure or hypertonia, hypotonia, if there is a regression of the developmental, if there is a moderate or severe with a specific disorder that is in your mind, phenotypically, there is something phenotypically support, there is maybe changes in the brain will help. For example, we have tuberous sclerosis, we have these kind of, that related with the neurological with maybe autism associated with it. So if there is no clear at the end, no clear, but still you have some disorders in your mind may support it, the changes maybe, or some metabolic diseases, for example, which is some of them reversible when you give management, you may find some MRI changes in the brain. So as we said, the benefit of neuroimaging, sometimes there's no any specific changes in the brain that will not add anything. And sometimes there will be a specific changes may support in relation to some metabolic disease like creatinine metabolism or white matter changes. I think that's it, and thank you very much.
Thank you very much, Dr. Zahra, for your elaborations in screening tools. We will have the floor now open for the questions. I will start with the first question from Dr. Muhammad. He is asking in Arabic: هل ينبغي أن ينتقل تشخيص اضطرابات النمو العصبي من الاعتماد على الأعراض السلوكية إلى المؤشرات العصبية والوراثية الحديثة? This, I think, Dr. Dalal answered this question.
السلام عليكم. فهو يتكلم عن التشخيص إذا كان عن طريق طبعا التشخيص في حالات الأوتيزم أو النيوروديفلوبمنتال ديليز تكون التشخيص كلينيكيا، والتشخيص مبني على الكلينيكي وليس التحليلات الوراثية أو الجينية. لكن إذا وجدنا في عامل وراثي مثلا علامات عند الطفل معينة كتأخر يعني تدهور في حالة في المهارات المكتسبة، أو مثلا تاريخ أسري قوي لأمراض وراثية أو أمراض التمثيل الغذائي أو أي علامات معينة من أمراض التمثيل الغذائي، ممكن أن احنا نعمل تحاليل يعني شاملة من ناحية التحاليل الوراثية.
فحبيت أكد على أن تشخيص اضطراب طيف التوحد والاضطرابات النمائية بشكل عام هو تشخيص كلينيكي، ما في فحص دم ولا صورة أشعة ولا تخطيط دماغ ولا فحص جينات ممكن يشخص الاضطراب، ولكن التشخيصات أو المؤشرات العصبية والجينية ممكن تساعدنا أن احنا نشوف العوامل الخطورة أو الأسباب التي قد تكون أدت إلى الاختلافات العصبية.
The second question is, can a neurodevelopmental disorder diagnosed in teenager?
Yes, it can be diagnosed, but with a condition that the concerns and the deficit presented from early years of life. So developmental disorder does not appear all of a sudden in a teenager age.
Ustad Ahmed Zamil asking, is there any law for protecting children with neurodevelopmental disorder from parent refusing accepting the diagnosis?
So I think the law will be the same for any child law. So there is a section for children with developmental disabilities. So yes, there is a national and international laws for children with developmental disabilities.
The problem with this type of disorders is the refusal of the family of accepting the diagnosis. This is also make a problem in looking for management and afraid from the stigma of the disease.
Yes, this can be an issue sometimes, like refusing or denial of the diagnosis. And I think that's why if we focus on the function of the child, the limitation of participation, and discuss this clearly to the family that we have to give the child this kind of intervention regardless of their diagnosis, I don't think any parent will refuse getting the intervention.
There is one question regarding, is any patient with a neurodevelopmental disorder need a pediatric neurology evaluation?
If there is no any focal neurological deficit, so we don't refer for a neurology. because there is now more subspecialty in neurodevelopmental disorder in relation that we, Dr. Ayat already speak about autism, ADHD, global developmental delay and intellectual disability. We are, as a developmental pediatrician and the child and adolescent psychiatrist, will take over this kind of cases.
Unless there is a finding for...
Yes.
There is one question regarding autistic spectrum disorder and finding of MRI of corpus callosal anomalies or agenesis. Is there any associations or a cause-effect linkage between the two?
It's not a specific finding. It's related to the autism itself, but it's a finding in the MRI. We need to refer these cases for a neurologist to discuss more about it.
By the way, the agenesis of corpus callosum or الجسم الثفني, it is not specific for autistic disease or other. Sometimes we find it in babies with only hypotonia, or sometimes it is not specific for the finding. There is one question to the organizer, I think, regarding getting the slides of the presentations of the doctors. What is the way they can get the slides?
One real per slide.
I think.
اللي حاب المعلومات اللي اليوم الدكاترة شاركوها معانا، ممكن تخلوا أسماءكم عند التسجيل في بداية عند البوابة الرئيسية، وممكن بعد طبعا إذنهم اللي حابب ممكن إن إحنا نشاركها معاه إن شاء الله. يعطيكم العافية. شكرا.
There is one question also whether ADHD, attention deficit disorder, can be diagnosed at age of 5 months.
5 months of age? No, so, and I think that's a valid question. I think we are a developmental pediatrician. We often see children 18 months, 2 years have a diagnosis of ADHD. And I think whenever you get a diagnosis for a child below, I would say 4 years of age, a diagnosis of ADHD should alert you for another diagnosis. Usually the primary disorder is autism or intellectual or developmental disability rather than ADHD. So ADHD is a school age diagnosis. So if we say our children going to a daycare and a preschool around the age of 4 years, so I would say that's the minimum age that you can diagnose. So 5 months of age, he's still even not sitting unsupported. I'm not sure how much of attention and activity you are expecting from 5 months of age.
Okay, so the youngest age that they can diagnose ADHD?
I would say around 4 years of age. If there is a persistence of issues in multiple environments, so he has to be in a daycare or a preschool, so you can assess thoroughly.
سؤال الساعة folic acid.
So keep your question to my second presentation. I have extensive discussion about that topic.
Okay. Is there any time more for? I think we have time to get a couple of questions more. Is there any Arabic version for Ritate test?
It is validated, but it's not published in the website. So there is an Arabic version. They are working on it, but still not in the website.
This is the last question. Can we diagnose ADHD in عمر الشباب?
Most of the symptoms will appear less than 12 years of age, less than 12 years of age. But There are some cases misdiagnosed. They are not diagnosed earlier. But when you take the history, you have to get the history. There was a history of hyperactivity or inattention symptoms before the even adulthood.
I think we will conclude now, and there is a lot of questions really remaining. I don't know if there is any way we can get to answer these questions either in between the sessions, if you have any specific questions to our great speaker. I would like at the end thank all the speakers and thank you attendees and thank the organizing committee for this nice organizations.
Honored guests, that brings this session to a close. And now we move forward into the prayer and break time. Refreshments are available in the hospitality area located to the left of the center main entrance. We would also like to remind you that the consultation stations are now open from 12:30 to 2 p.m. for families who wish to ask questions and meet with the multidisciplinary medical rehabilitation team from Eiffel Medical Center, as well as educational rehabilitation team from Eiffel Daycare. And this will take place in the reception area. Please note that the returning to the hall to resume the sessions will be according to the scheduled time for the next session in the forums program. Thank you very much. Honored guests, our next session for the day focused on evidence-based interventions and therapies. This session will feature Dr. Sara Silsila, Dr. Turki Al-Biti, and Dr. Ayat Al-Wahid. This session will be chaired by Dr. Zahra Al-Faraj, a developmental pediatric consultant at the Ministry of Health in Riyadh. With a great pleasure, I invite you to the stage. حضورنا الكريم، للتذكير في حال رغبتكم باستلام أجهزة الترجمة الفورية يرجى إبلاغ المنظمين بتزويدكم بها.
Good afternoon. So after early diagnosis, what's come next? The most important step after the diagnosis is the intervention. As we said, early diagnosis make a difference. So we're going to have a look through the early intervention. We will start with, to welcome to our second sessions, titled Evidence-Based Intervention and Therapy. This session will focus on advancing behavior intervention and pharmacological management and integrative approaches for children with neurodevelopmental disorder. As before in the previous sessions, you can ask your questions through the SMS or through the QR code that they share with you. Our first speaker is Dr. Sarah Silsila, is a doctoral level board certified behavior analyst and the co-founder and managing consultant of the Seeds of the Knowledge for education and behavior consultation. She has over 10 years of experience developing and implementing applied behavior analysis-based programs for children with and without disability in a school and clinical setting. Dr. Silsila earned her master and PhD in applied behavior analysis from Teacher College, Columbia University, New York. She will present advances in behavior intervention, highlighting evidence-based strategies to support children with neurodevelopmental disorder. Please have a warm welcome to Dr. Sarah Silsila.
Hello, 1, 2. Assalamu alaikum, everybody. It is really an honor to be here, and I really appreciate this opportunity. Today, I would like to talk to you about the advances in applied behavior analysis. I'll give you like a brief introduction about what's happening in applied behavior analysis, and then we'll go and talk about each one of them in details. So the field of applied behavior analysis is pretty young. We're about 60 years old. So it is constantly evolving. How it looked 10 years ago, it's not how it looked today, and it's not going to be how it looks in 10 years from now. We are a young, agile field, and we're constantly evolving. This particular area or phase of applied behavior analysis is very exciting. There are a lot of changes into the right direction, and thankfully so, because the science of behavior analysis is undeniable, right? We have a lot of evidence to support its use with supporting children with autism or individuals with neurodevelopmental disorders, because we have the science and the tools to tell us how human beings learn behavior. And that science is undeniable. What we're working on as a field in this day and age is to make sure that the practice coincides with the science. So right now, the science is undeniable, but the practice of behavior analysis is continuously changing. So what is changing in the field of behavior analysis? There's obviously a digital revolution, which we are all feeling, which include telehealth and the use of artificial intelligence. There's also a very big shift in the way applied behavior analysis is implemented. It's moving toward individually based interventions rather than therapist-led interventions, which includes assent-based interventions and trauma-informed care, which we'll talk more about. And then finally, we're going to talk about establishing a more holistic approach when it comes to practice, so that behavior analysts are not working on one side and everyone else is working on another side, but actually we're all working together to improve client outcomes and shared common goals. Oops. All right, one of the most important advances in behavior analysis is telehealth, which means providing behavior analytic services remotely. So I can be in Jeddah, someone else can be in Umluj, literally something I'm doing now. I'm in Jeddah and my client is in Umluj, but I'm able to provide behavior analytic services to them because we have this technology, which really became more, it was always there, but it became more famous after COVID when all the behavior analytic clinics, stopped, and we had to find a solution to make sure that services continue and there's no cut in services and client outcomes are still reached. So telehealth is a very important part of what we do now. And the nice thing about telehealth is you can work with the client directly. You can train the parent to implement the procedures. You can coach the parents who are experiencing behavioral challenges, which makes it very accessible. They don't have to be in the same room. They don't have to come and transport themselves to you, so they're saving. It's efficient, and even there's no overhead cost for an actual clinic. It's fast, it's agile, and it's nimble. So these are all the important aspects of telehealth. There are downsides of telehealth. It's not for everyone. If you have nonverbal clients who have a hard time sitting down, it's going to be very hard to sit them down in front of a screen and allow them to get intervention in that way. So in that case, you can train the parent, and you can use that technology to train the parent. You can put an AirPod in their ear, and you can tell them, coach them through a camera what to do. So that's really nice for areas where ABA services are not available. But again, there are issues, so privacy issues. Essentially, cameras that are in homes capture things that maybe you're not supposed to capture because you are in a private setting. So there's a privacy issue, and there's also the issue that it's not for everyone. There's specific profile for who can get telehealth in this kind of treatment. So that's telehealth. Another major advancement is artificial intelligence. The research here is much slower than the actual advances. So AI is out there, and it's moving, and it's not stopping. And the research is kind of like still over here, and AI is over there. But slowly, it's making its way to understanding what is AI, how can we use it in behavior analysis. There are some studies nowadays that have used AI into intervention. For example, they have smartwatches now that detect heart rate and biological responses within session to give therapists feedback about the client's state, and in turn the therapist can change the way that they are interacting. There are apps now that also you program in the app what the expected intervention is, and it gives the therapist in real time treatment decisions that free up the therapist's space, like brain space, to be with the client. And they also have virtual realities and robots that can help create a safe space for some of the individuals with anxiety to practice social skills and language communication and that kind of thing. There are obviously downsides. It's still a very under-researched area, and there needs to be a lot more research in this area, but again, we're still catching up. It's moving way faster than we are. But we have to make sure that it supports intervention and does not replace it, right? There is, especially in human service, we cannot replace it with an AI or a robot. It always needs to support an actual human clinician, because you can potentially run into isolation if they keep practicing social skills with a robot and not in real life. That it's not meant to replace that human connection, because that human connection is actually felt, and it's really important for the therapeutic alliance to have that human connection. So it's very important to always recognize that AI is there to support our interventions and never replace them. And relying too much on them can potentially cause a lot of issues, specifically a decline in critical thinking for the therapist and the clinician. If we let a machine think for us all the time, we will lose that ability to make those in-the-moment decisions and treatment clinical decisions, and we never want to lose touch of how our client is responding to us and our ability to respond to them. Because that therapeutic relationship is one of the most essential aspects of behavior analysis or any human service, treatment, interventions. And to quote a floor time therapist, most of the time, connection is the intervention. Just the fact that you are there as a clinician, developing a therapeutic alliance with the individual is healing in and of itself. So if we take that out and we allow a machine to think for us, it can become very dangerous. So that's my little warning about AI. Okay. Which brings us to assent-based intervention. Thankfully, behavior analysis we're seeing a huge shift in the way we are implementing it. It is no longer, I am the therapist, you are the client, I tell you what to do, and we're gonna teach you how to comply and sit in a chair and look into my eyes. That kind of ABA is no longer acceptable. And a huge part of this revolutionary shift comes from us listening to the autistic community and telling us, this is not okay. You cannot tell us to do it or do it in that way. And if we are ethical behavior analysts, we listen to the people we are serving, right? We have to listen to the people we are serving. If they are telling us this is not right, then we need to listen. And thankfully, the field is listening, and we have a lot of shift and movement in the way we are providing behavior analytics service. So it's no longer compliance-based, therapist-led. It is actually now client-led and assent-led. One of the most important movements in behavior analysis is assent-based intervention. And what does assent-based intervention mean? So assent-based intervention is like consent. You know, before you get treatment, the parent or guardian signs a consent. That's one thing. Assent is the client themselves have to agree to treatment. So if I'm in a session with a client, with a little child or individual, adolescent, and at any point they run away from me, that's a really bad sign. That means there's an assent withdrawal. There's a dissent. So that means they don't want to be in your session anymore. We as therapists need to make sure that we are very sensitive to these little changes and shifts in what they're doing, because if we are not, we risk hurting that therapeutic alliance I was talking about. So in order to have this therapeutic alliance and really provide effective treatment, then we need to always make sure that willingness to engage with us, that the client is happy, relaxed, and engaged, HRE. By the way, that's a term in behavior analysis today. Happy, relaxed, and engaged. You need to make sure that whoever you're working with is always happy, relaxed, and engaged. Bad signs or signs of dissent or assent withdrawal means that you have to change things. So if a client is running away from you, if they cry a lot.
2 minutes.
Oh no, I have so much to say. I'm gonna get through as much as I can, and inshallah khair. Trauma-informed care, and then, all right, 1 minute to go over this. So again, we're moving away from the more structured ABA environment, more naturalistic environment, so that we can promote skills across settings, not just clinic. We want to go into the homes, we want to go into the schools, we want to teach those skills in play, because we want to make sure that we promote generalization across settings, and it's not just a table with the clinician and cards, apple, bear, chair. That's not how language is taught anymore. Like, that's not how typically developing children learn, and that's not how autistic children are going to learn language. And if they do learn language that way, it's going to be limited, all right? So that's why we have a shift to more naturally based interventions, like pivotal response training, early start Denver model, and Jasper. I'm going to move into interprofessional collaboration really quickly, and then, so again, a major shift in behavior analysis is because it's a young field, we are missing a lot of framework on how to collaborate with others in the field. So the Organization of Applied Behavior Analysis International gave us the framework of WHO, or the World Health Organization. So we are following the framework of collaborating with others, professional speech pathologists, occupational therapists from the medical field, because it's a very advanced area in that field. So the days of a behavior analyst doing their own thing are over. Behavior analysts must and always should collaborate within a team of professionals. We cannot just, behavior is not, it doesn't exist in a void outside of everything else. So we need to make sure that we consult a speech pathologist for language. We consult occupational therapists for handwriting. We know the science of learning, but they know the ins and outs of what needs to be taught. So this collaboration will create a better, more holistic approach towards effective ABA therapy. And then finally, to end, I have 1 minute. I have 5 more minutes. 1 more minute. This is a really important area, and it's fairly new. It's a behavioral sciences approach towards mental health. It is, there's a huge comorbidity, like Dr. Ayat was saying before, between, individuals with developmental disabilities and other disorders or anxiety or depression. So we really need to look at providing mental health support to the individuals that we serve. And there's a lot of movement in that area as well. One such areas is acceptance and commitment therapy. It's not necessarily based on applied behavior analysis, it's contextual behavioral sciences, but its basis in behavior analysis, and it's basically understanding those private events or the things that happen inside of the individual, not just the observable behavior, but their thoughts and their feelings, and helping them understand their thoughts and their feelings as well, so that they are able to make progress. And I found this personally to be very helpful for adolescents with autism. The young ones, they'll benefit from that one-to-one play, playful interactions, like the natural intervention approaches. But the older ones who are struggling to make friends, who are having hard time socializing, these kind of therapies are very important for them, so that they can begin to understand what's happening inside them and the relationship between what's inside and their behaviors. Once they themselves understand that relationship, you'll see amazing changes. It's really incredible. And then finally, you have nonlinear contingency analysis. More traditional ABA focuses on a linear analysis, antecedent behavior consequence. But for nonlinear contingencies analysis, we're looking at multiple contingencies at one time. Is this my cue? Is that my cue? Okay. Right, so to conclude, this is a really important area. Research is still under development, but there is promising research as well in this area. And it is really an area that we need to look at, especially in supporting autistic individuals or individuals with disabilities across the ages, not just in early intervention, but also when they are older, who is going to be taking care of them and allowing them to thrive in society. And I'll end with that. Thank you so much.
Our next speaker is Dr. Al-Bati, a child adolescent psychiatry consultant. He completed a fellowship in child and adolescent psychiatry at the University of Michigan, USA. Dr. Al-Bati is an academic and expert in neurodevelopmental and behavior disorders, early diagnosis and intervention program, as well inclusion strategies. He will speak about, as we finish the behavior therapy intervention, he will be speaking about pharmacological intervention for ASD and ADHD, reviewing the recent guideline and the safety consideration for clinical practice. Please have a warm welcome to Dr. Tur.
السلام عليكم، مساء الخير. سعيد بتواجدي معكم وسعيد بالدعوة الكريمة والزملاء والزميلات. 20 minutes to summarize the medication لل-ASD and ADHD is too much. فأنا I prepare file فيها 4 guidelines بالعربي وبالإنجليش. واحد عن ال ASD، واحد عن ال ADHD، I will provide it. Anyone can take it في update. أبحاول في 20 minutes هذه نسوي كذا summary بسيط يساعدنا كلنا كمختصين how to understand أهمية التدخل الدوائي في اضطرابات ال ASD and ADHD. I hope it will be very helpful إن شاء الله وبكلمات بسيطة ونقدر نستخدمها في حياتنا اليومية. أنا أقدر أجيب أرقام، لا أبي شيء كذا بسيط message to take home نستفيد منها كلنا في نهاية اليوم. طيب نبدأ الشرايح. 9 minutes ولا 20؟ أوكي. أي أوكي. طيب. طيب. طيب خلاص اشتغلت الجهاز هذا. طيب بالبداية بيكون تركيزنا اليوم على ال evidence based medication only. ما راح أتكلم عن أي أدوية جديدة لأن we have not too time to talk about a new medication. السؤال المهم، متى نحتاج التدخل الدوائي؟ هذا السؤال المهم. When we should consider pharmacological treatment. إذا كان عندنا شيء اسمه functional impairment. إذا عندنا functional impairment, we need to interfere with the medication. If we don't have functioning impairment, don't add medication, especially with the kids. It's very important. Sometimes easy access to give the child medication, but on the long term, you will have a lot of side effects compared to the benefit. Although initially we can give some benefit from medication, لكن on the long term, no, it will be more harmful than helpful for the child. So if we have functional impairment, we can start medication. Otherwise, we don't have the role of medication, especially in ASD autism. What we expect from the medication, either to reduce the core symptom, especially in ADHD, or improve the function, especially in ADHD and sometimes ASD, and support behavioral therapist. بعض الأحيان الزملاء المعالجين يقول لي دكتور البيشنت هذا عنده قابلية بس الولد ملول يطفش، تروح 10 minutes from the session بس جالس يتحرك. We believe إنه he or she can get benefit لكن قاعد يضيع جزء كبير من الجلسة في inappropriate behavior. فالتدخل الدوائي في مثل هالحالات يفيد الأطفال. دائما the top priority for the child is safety, then safety, then safety. أهم من قضية إنه let's start medication right now. Always consider موضوع السيفتي. Okay, let's start with ASD, autism. First of all, no medication treat the core social communication deficit. ما في دواء إلى الآن يعالج الأعراض الأساسية للتوحد اللي هي ضعف التواصل الاجتماعي. ما في دواء يحسن الجوينت اتنشن، ما في دواء يحسن الاي كونتاكت، ما في دواء يحسن البوينتنج أو الريسبوند تو نيم أو البريتند بلاي. هذا يعطينا أن الأدوية في الاس دي مهمة لكن ليست هي الأصل. الأصل to treat with the child with non-pharmacological intervention, speech, psychology, ABA, occupational, rehabilitation, whatever, PT, OT, but don't think that the medication have a big role in ASD. How we target, متى نبدأ التدخل الدوائي؟ إذا كان عندنا 4 أشياء. إذا كان عندنا irritability بدأ الطفل يصير قلق، aggressive خصوصا مع الأطفال الأوتيزم النون فيربال، أو هايبر اكتيفيتي as a comorbidity، أو بعض الأحيان هايبر اكتيفيتي اللي نشوفها مع الاي اس دي، أو عندنا مشاكل في النوم. ما في إلا دوايين علميا مثبتة لعلاج التوحد خصوصا في موضوع الإريتابيليتي والأجريسيف. الريسبريدون هو بالنسبة لنا دواء سحري ما يفشلك أبدا، تخليه جنبك، يبي يساعدك في النوم، في الأكل، في العصبية. بس السر والسمارتنس how to use it in a proper way. ما يفشلك أبدا ريسبريدال، خلوه جنبك، بيساعدك في كثير من الأحيان. بس متى وأعطيه المن والمدة كم، هنا يجي فن استخدام دواء الريسبريدال. إذا ما استجاب الطفل للريسبريدال لأي سبب ما، ممكن نروح للدواء الثاني اللي اسمه الأريبيبرازول، أرابينا، زوليندا، هذه أسماء تجارية. إذن علمياً ما في إلا دوايين مسموحات تستخدم في التوحد، الريسبريدون أو الأريبيبرازول. هل في أدوية ثانية ممكن تستخدم؟ نعم، لكنها ما هي مثبتة علمياً، زي الكلونيدين اللي هو يعتبر ألفا 2 أجونست، هو علاج ضغط لكن نستفيد منه بعض الأحيان مع بعض أطفال الأوتيزم، أو الجوانفيسين أقل أعراض جانبية من الكلونيدين. إذا صار عند الطفل قلق ولا اكتئاب whatever kind of comorbidity، فاستخدام مضادات القلق أو الاكتئاب يساعد الطفل. ميلاتونين for sleep، أنا I recommend every child with autism have a sleep problem start with melatonin، لأن واحدة من الدراسات تقول إنه 75% من أطفال الأوتيزم عندهم مشكلة في الميلاتونين، والميلاتونين it's a safe medication، يعني ما يقارن بالريسبريدون. فعطى الطفل ميلاتونين يساعده على النوم، end of the day ما يعتبر chemical medication، فالميلاتونين is very safe. فأنا أفضل أن يعطي بيشنت ميلاتونين ولا أن يعطيه ريسبريدون عشان ينام. فالميلاتونين more safer for sleep. تعطي الطفل 1 ملغ، 3 ملغ، 5 ملغ، 10 ملغ، ما يضر. أفضل من أنك you keep the child على 0.5 ملغ ريسبريدون عشان فقط ينام أو for any other reason. أغلب أدويتنا هذه فيها مشكلة أنها cross blood brain barrier، فتسبب بعض الأعراض الجانبية خصوصاً الميتابوليك، زيادة الوزن، شراهة الأكل. ودي أشرح لكم مثال فقط ليش أطفال اللي يأخذون ريسبريدون يصير عندهم شراهة بالأكل. واحدة من الأعراض الجانبية للريسبريدون إنه يفتح الشهية للأكل. وش هي الميكانيزم؟ أن الريسبريدون يروح للبرين ويروح لمنطقة الجوع ويقول للطفل تراك جوعان، تراك جوعان، تراك جوعان، تراك جوعان، مع أن الطفل يصير توه ماكل وجبة دسمة. فيلاحظون بعض الأهالي أن الطفل متغدي heavy meal then after 15 minutes يروح للثلاجة ويفتح الثلاجة ويأكل، إلى بعضهم درجتهم يستفرغ. السبب السايد افكت في الريسبريدون. فالريسبريدون يفتح الشهية للأكل لأنه يروح لمنطقة الجوع في الدماغ ويعطيها false negative that you are hungry, you are hungry, you are hungry، فيروح يأكل الطفل بطريقة indirect. فالأعراض الجانبية للريسبريدون والأدوية هذه تحتاج أننا keep an eye for the child. إذن دائما we think about the safety, then safety, then safety. وإذا اضطرينا نعطي أدوية always monitoring for the side effect. طيب let's focus على الريسبريدون، لأن I believe إنه هذا ما في أحد في القاعة ما كد سمع أو عنده patient أو whatever. دائما أنا أقول للأهل إذا بغينا نستخدم الريسبريدون لازم نجاوب على 3 أسئلة. ليش أنا أبغى أعطي الريسبريدون؟ For how long and what is the dose؟ لازم نكتب من day one what is the reason I use the risperidone. أنا أبغى ولدي ينام، أبغى ولدي تروح عنه البيكي إيتر، أبغاه ياكل، أبغاه ما يكون أجريسيف. لازم نكتبها لأن الأعراض هذه لو تحسنت within 5 days حوقف الدواء. It's not safe to keep the risperidone forever. فإذا أول طلب أطلبه من الأهالي يقول لهم خلونا نتفق why we use risperidone. The second question for how long. غالباً it's safe to give the child risperidone for from 4 to 8 weeks. It's very safe. في الغالب no side effect. If you go beyond 8 weeks ترى غالباً you will get a couple of side effects. فإذا كنت سمارت في قضية how to use it يعني it's a black magic medication. Anxiety, aggressive, insomnia, hyperactivity, but learn how to use it and what is the time. And last option about the dose. It's very safe to give 0.5, 0.75, 1 ml. لكن usually if you go beyond than 1 ml, ترى في الغالب you will gain more side effect rather than to get some benefit. It's very safe to start with 0.25, 0.5, 0.75 up to 1 ml. لكن ترى بعد 1 ml لا تتوقع a lot of benefit versus we will gain more side effect. فإذا دائما أنا أقول للأهالي خلونا نجاوب على الأسئلة هذه قبل ما نبدأ. I give them space how to tailor the medication. ليش حنا ناخذ الدواء واعطيهم range of dose they can titrate the dose واعطيهم duration معين وبعدين اقول لهم ارجعوا لي في النكست فيزيت. نفس الكلام ينطبق على الاريبيبرازول من ناحيه اعطاء الدواء، لاننا ما نتوقع ان الدواء يعالج اشياء ميجر عند الطفل. فواي تو keep the child on medication for 1, 2, 3 years or risperidone. انا بالنسبه لي I will be very upset in the clinic when I saw a child يقولوا لي الأهل والله احنا لنا 4 years على الريسبيريدون. لا أنا أعتقد أن هذه واحدة من الارتيكل كانت كاتبين it's a crime to keep the child on risperidone for long period. فهذه نقطة مهمة جدا to keep the medication without good justification. الشغلة الثانية monitor side effect. دائما حط عينك على السايد افكت. زيادة الوزن، شراهة الأكل، ارتفاع هرمون الحليب، ارتفاع الدهون، وارتفاع السكر. weight gain, increase prolactin level, increase lipid profile and decrease blood sugar level, keep an eye. فلو جاني patient تحسن على 0.5 وهذا one of the best medication I do monitoring for side effect, this is no problem to keep the medication for another couple of weeks. Unless I keep control على موضوع السايد افكت I keep monitoring على الأعراض الجانبية اللي تجي مع الدواء وما تكون واضحة بالأعراض زي ارتفاع هرمون الحليب وارتفاع الدهون والسكر. إذن in conclude, risperidone number 1, keep it in your right hand. يبي يبيض وجهك في كل المحافل لكن use it in a smart way. وجاوب على 3 أسئلة. Why I use risperidone? For how long? What is the dose that I can play with it? يعني باختصار أنا أعتقد أن الريسبيريدون هو من الأدوية الحلوة لكن لازم نطلع بهالهايلايت هذا يساعدنا في فهم استخدام الريسبيريدون. بالنسبة لل ADHD فرط الحركة وتشتت الانتباه إلى الآن يبقى الستيمولنت اللي هو الميثايل فينيديت اللي هو إما الريتالين أو الكونسيرتا هو one of the best medication. إذا كان عندك طفل صغير you want to start وزنه 18 الأفضل أنك تبدأ بالريتالين لأن الريتالين عبارة عن 10 ملغ حبة صغيرة I can break it put it with fluid liquid فهذا يساعد كثير. ما أفضل أن النايف بيشنت نروح على طول للكونسيرتا لا خليك على الريتالين. لكن لو جاك طفل عمره 9 سنوات والويت 30 you can start with كونسيرتا 18 ملغ لأن الأدوية هذه مرتبطة بالكيلوغرام فال1 ملغ equal to 1 كيلوغرام فهذه تساعدك كيف تعطي الدواء المناسب. فالريتالين الأفضل دائما نبدأ بالريتالين مع الوقت ممكن نروح للكونسيرتا هذا من ناحية الأدوية الستيمولانت. طبعا في أدوية ثانية زي الأديرال زي أنواع كثيرة لكن هي end of the day it's a salt ملح فلما نعطي الدواء it's عبارة عن salt عشان كذا هو من الأدوية اللي من أول دقيقة من أول جرعة من أول يوم I can know this medication will help the child or not عكس الريسبيريدون أو الأدوية الثانية أو أدوية الاكتئاب. فالريتالين والكونسيرتا من الأدوية اللي من day one I know what will be the next step for the child. هذه الأدوية عكس أدوية الأوتيزم. هذه we will use it for ما ودي أقول lifelong لكن we need it. فلما يجي طفل كلاسيكال ADHD الأفضل أنه يبقى على الدواء up to age of 12, 15. Then later on the child himself or herself will decide أنا أحتاج الميديكيشن ولا لا. فالأطفال هذول لما يكبرون يصيرون أولى متوسط they know how to use the medication. but sometimes يقول لا دكتور أنا الآن ما أحتاجه. لما يجي الستريس الإكزام يقول لا I need the medication فنقدر نعطيهم. لكن minimum 4 to 6 years keep the child on Ritalin أو Concerta. في side effect we can manage. مثلا الطفل ما يأكل خلاص جمعة وسبت ما يأخذ الدواء. فهذه من الأشياء التكنيك اللي تساعدنا في استخدام الأدوية. طيب لو لأي سبب ما تحسن الطفل على الريتالين أو الكونسيرتا السكند لاين هو الأتوموكسيتين اللي هو الاستراتيرا. الاستراتيرا يشتغل على التركيز فقط. فهذا إذا كان الطفل أغلب مشاكله قلة تركيز فالأتوموكسيتين رائع. يوجد منه شراب ويوجد منه حبوب. الشراب يروح ويجي بس إنه مريح للأطفال سيرب أوف أتوموكسيتين. لو الطفل ما استجاب على الأتوموكسيتين لأي سبب ما فاستخدام الجوانفاسين أو الكلونيدين ممكن يساعد الطفل. وش نتوقع من الأدوية هذه؟ الأدوية هذه it will back the child to normal. عشان كذا we keep them this medication for long period. لأن الأطفال هذولا attention, hyperactivity, impulsivity سببها نقص مادة الدوبامين. فأنا لما أعطيه دوبامين أجونست حترفع مستوى الدوبامين حيرجع نورمال تشايلد. فالإمبلسيفيتي هايبر أكتيفيتي إن أتنتيف لأنهم هذول الأطفال بالفرونتال لوب بالإكزيكوتيف فانكشن ما عندهم دوبامين. فكيف تبغاه يعيش بدون دوبامين؟ فلما نعطيهم الدوبامين أجونست اللي هي مشتقات الميثايلفينيديت نشوف الطفل تغير حياته 180 درجة. Choose medication based on comorbidity and tolerability. طبعا دائما الأهالي يشتكون من الأعراض الجانبية. ما يشتهي الأكل، ينزل الوزن، ما ينام. فهنا عاد يجي دور الطبيب في اختيار الدواء المناسب. Plus إنه sometimes this medication تسبب أعراض جانبية مثل تكس. فلما ناخذ ريتالين وكونسيرتا نلاحظ إن بعض الأطفال بدأ يصير عندهم involuntary movement. فممكن يسبب لهم تكس. ممكن يسبب لهم anxiety. فممكن يسبب لهم قلق. ممكن يسبب لهم epilepsy sometimes. فاستخدام الأدوية هذه يجب أنه يكون مقرون بالسايد افكت والكوموربيديتي. فلو كان طفل عنده قلق أو تكس فالأفضل أنك ما تعطي ستيمولنت. Go with atomoxetine وهكذا. فالأدوية في ال ADHD it has a big role but not the only role of ADHD. يعني لا تتوقعون أن الطفل إذا أخذ ريتالين ولا كونسيرتا he or she will back to normal without other kind of intervention. علاج ال ADHD 4 أشياء: medication, psychotherapy, family therapy and educational therapy. فلازم يكون في individual session with the child. لازم الأب والأم والفاميلي يأخذون شيء اسمه positive parenting الوالدية الفعالة. ولازم المدرسة يروح لها report how to deal with the child inside the classroom. فلا تتوقعون أن الدواء alone في ال ADHD حيعطي big improvement. الطفل نفسه بيتحسن لكن he needs support from other services الوالدين المدرسة والطفل نفسه. فالأدوية مهمة في ال ADHD عكس ال ASD. ال ASD الأصل أنك تبقي ال child without medication and if you need medication keep it BRN or for يعني short time of period. ال ADHD لا الأصل to keep the child on medication لكن monitor side effect إذا كانت تزعج الطفل. يعني على سبيل المثال طفل متحسن أموره تمام في الصيفية ما عنده أي activity خلاص ما يأخذ الدواء 2 months ما يأخذ الدواء ما يضره أبدا. يوم الأحد عندنا دراسة يأخذ الدواء الأحد الصباح يرجع طبيعي، ما هو من الأدوية اللي تحتاج أن الطفل to keep it long period. فال ADHD الأصل هو بقاء الطفل على الأدوية عكس ال ASD. طيب safety consideration، الويت، الابيتايت، سليب. دائما الأهل اللي يأخذون أدوية الستيمولنت يقولون عندنا مشكلة بالشهية الأكل، ينزل الوزن، واضطرابات النوم. نزول الوزن وعدم شهية الأكل نطمن الأهل إن شاء الله هذه ترانزيانت ومع الوقت تتحسن. إذا ما تحسنت نخلي شيء اسمه دراج هوليدي اللي هي جمعة وسبت. النوم أول ما يصير عنده اضطراب النوم عطوا ميلاتونين، تصير أموره تمام ويتحسنون بشكل كويس. دائما الأهل يسألون على الأعراض الجانبية للقلب. إذا ما في تاريخ عائلي لإصابة بأمراض القلب أو sudden death ما في داعي إنك تخلي الأهل قلقين وتخليهم يطلبون تخطيط للقلب. لكن لو كان في family history of cardiac disease أو sudden death فالأفضل إنك تطلب للطفل ECG قبل ما إنه يبدأ الستيمولنت.
1 minute دكتور.
أوكي. Behavioral side effect and risk benefit discussion. دائما keep the family with you على موضوع السايد effect و how to manage السايد effect. Gradual titration and clear target treatment goals. دائما أقول للأهل نبدأ small go slow حتى نصل للجرعة المناسبة. ما يصلح تبدأ جرعة عالية لأن هذا حتكون تروما للأهل، فابدأ بجرعة خفيفة ومع الوقت تتحسن الأمور الثانية. Important of multidisciplinary monitoring. طبعا كل ما كان معك فريق يساعدك في معرفة الأعراض الجانبية، المعلمين، الثيرابيست، الوالدين، هذول يعطونك نظرة أعمق. Shall I continue medication or not؟ بالنسبة للريسنت جايدلاينز هي تركز على إنه early assessment and combined therapy approach recommended. كل ما كان في تقييم قوي قبل ما نستعجل باستخدام الدواء حيكون شيء مساند أو مهم. Combined therapy approach recommended. Don't believe that the medication alone it will help the child. في ال ADHD has a big role لكن not the only solution. في ال ASD it has a minimum role compared to other behavioral therapy. For ASD medication only for specific challenge behavior. إذن الأصل the rule to keep the child with autism without medication, and if you need it, it should be for specific challenging behavior. In for ADHD, stimulant remain first line unless contraindicated. ريتالين، كونسيرتا تخلي الطفل يعيش حياة جميلة وكل شيء كويس وتكون الأمور أفضل. Shared decision making with the caregiver. أنا أسوي طريقة في العيادة ومريحتني من أكثر من 15 سنة. لما أتخذ قرار في الدواء ما أنا أتخذ القرار. أقول للأهل إنه في ريتالين وفي كونسيرتا. Go and read. Back to me next week and we discuss what is the best choice for your child. Always do something with the patient rather than do something to the patient. Always do something with the patient rather than do something to the patient. ليش؟ لأنك إذا دخلتوا معك بالقرار حنصير شركاء بالنجاح أو شركاء بالإخفاق. لكن لما تتخذ أنت القرار he will blame you في النكست فيزيت. فالأفضل دائما أقول للأهل go and read وباك تو مي. يقولون لي بس أنت الدكتور اختر. أقول لهم أوكي أنا الدكتور، لو فيه ريسك وبنفيت بقول لكم إن هذا ما يصلح لابنكم. يعني لو جاني مريض أوتيزم ووزنه 80 أقول لهم نو رول تو ستارت ريسبريدون، نو رول. لكن لما مثلا يقولوا لي ريتالين ولا كونسيرتا أقول لهم أوكي جو ريد باك تو مي. فدائما أشرك الأهل بالقرار وهذا ما يقلل من قيمة العلميين، بالعكس الأهل يحترمونك. Last thing, regular follow-up and dose adjustment based on respond. دائما في البداية keep an eye، خلي الله يجون كل أسبوعين كل 4 أسابيع. بعدين لما يكون في مرحلة المينتنس ممكن كل 6 شهور خصوصا في حالات ال ADHD. لكن في حالات الأوتيزم لا. You should look carefully for the child. Thank you. شكرا.
Well, thank you, Dr. Bati, for the thorough information. So our final speaker for this session is Dr. Ayat Al-Wahid, a developmental pediatric consultant and program director of Developmental Pediatric Fellowship at King Abdullah bin Abdulaziz University Hospital. She will give a highlight talk about integrative and holistic approaches for neurodevelopmental disorder. Please have a warm welcome to Dr. Ayat.
Assalamu alaikum. Can we have the slides? Okay. So during the coming 15 to 20 minutes, I'll be talking about the integrative holistic approach in autism therapy. And I know that's an area that is really rich in questions and debates. Parents often in the clinic will have at least one or two questions about one or more of these modalities. I'll talk a bit also about the complementary or alternative therapies. So first, I'll explore with you some of the terminologies that we use. So when we say a conventional medicine or conventional therapy, we mean that those are the physician-based, evidence-based interventions like speech therapy, OT, ABA, that we commonly prescribe and refer for in our clinics. Complementary medicine, which is usually therapies that is used in addition to the conventional therapies. Alternative medicine, what usually parents use instead of the conventional therapy. And the integrative medicine or therapy, when we say integrative, so we mean we integrate multiple evidence-based therapies, including developmental pediatrician, child and adolescent psychiatrist, OT, PT, ABA, and even family support and mental health, in addition to the evidence-based complementary medicine if applicable. And holistic term means that we take the child as a whole, like in all dimensions, biological and neurological, sensory, behavioral, cognitive, social, family, and environment. So it's a whole family, a whole child, the whole environment. And the therapy or medicine should be intentional, goal-directed. And as I discussed in my first talk, it should be based on function. What we want this child to improve and it should be monitored frequently for progress and improvement. So what are the key components or part of the ICAM or integrative complementary alternative medicine? So it should have the evidence-based therapies. It should be individualized. So every child need to have his own individualized plan. Multidisciplinary approach and family center. And I'll try to spend some time on the family center approach because we said the family is the partner in all this way. So how evidence usually evaluated? So when we talk about the conventional, usually it's evaluated through RCTs, peer-reviewed. But when we talk about complementary, most of the complementary, it's an observation, uncontrolled observations. It's a parent experience or a client experience. And some of these benefits we usually see with the CAM can be biased because it could be due to placebo effect. It could be due to the natural developmental progress of the child, or even the effect of concurrent therapy like ABA or speech or other interventions. And when we say lack of evidence, that doesn't mean this medicine or this approach is working or not working. It means that we don't know much about this intervention. It means that we don't know the long-term effect or the long-term side effect. So we really need to be careful. About 75% of families of autistic children will explore the complementary therapy. And why usually families will approach complementary therapy? Usually they are afraid from the medication side effect. Complementary therapy is usually considered or thought to be natural and more safer than pharmacological or other therapies. Limited response to the conventional treatments, and sometimes because they don't have access to those conventional or evidence-based approaches. Okay, so you will see these different lines, colors. So that's the way we should use when we try to assess the complementary medicine. So green means that this approach could be a low risk or has a possible benefit to the child. Orange means this approach have a moderate risk or uncertain benefit, yani maybe. And the red means it's either high risk or evidence has proven that it's a low benefit approach. So during the coming few slides, I'll focus more on the orange because the green, it's already proven, most likely, and the red also proven that's ineffective or risky for those children. So one of the most common actually complementary is the diet or supplement, although most of it is not even a new, but we still, at least in every clinic, 1 or 2 families will ask about this approach. The most common is the gluten casein-free diet, and it's based actually on the unproven theory of leaky gut. So it works on the gut-brain axis, like there are a peptide that will go to the brain and will affect the brain function. Most of these studies actually showed, and this term you will hear it with every therapy, this diet will not affect the core symptom of ASD, and this is something proven. So it will not treat the social communication, but it might be beneficial in subgroups who have some or significant GI symptoms, constipation, diarrhea, bloating, so on and so forth. Especially for this diet, probably celiac, lactose intolerance, they could benefit from this approach. And we know diet restriction is really difficult with autistic children because most of them are selective eaters. So it will be a big burden for the child and for the family. And if we remove something from the diet, so we are exposing this child for nutritional deficiencies as well. And this requires a medical and dietitian supervision. Another diet is the ketogenic diet, which is initially, or it's used widely for some kinds of seizure or epilepsy. And it's followed the same approach, like gut-brain axis. Studies showed that it will not affect the core symptom of ASD, but some of the small RCT studies showed maybe there is some improvement on the attention, processing speed, some of the irritability, reduced hyperactivity, and some of them also said that it could affect the severity scale of ASD. But again, the core symptom will not be really effective. Similar challenges. I'm sure most of us have tried the special diet, so it's really a burden for the family to stick and to adhere to this diet, with the similar risk of nutritional deficiencies as well. Low FOD MAP diet, that's another diet which works on reducing the fermentable carbohydrates, same concept, brain-gut axis. And again, studies has shown that it can improve the GI symptom, but not the core symptom of ASD. So I think that is something, really we should explain it to the families who wants to explore this option. Like, what's your target? What you are hoping for? Are you hoping to improve the ASD features? So it will not help. But if your aim is GI, that could help. And we know sometimes if you control some of the GI manifestation, this can reflect on the behavior. Less irritability, better sleep, better behavior, but again, not the core symptom of ASD. So the take-home message for all these different diets, that current evidence is insufficient for routine use, and those will not treat the core symptom of ASD. They should be considered for a subgroup, especially those with epilepsy or GI manifestations. And if considered, should be for a limited time and should be monitored, and we should not replace the conventional evidence-based therapies. Some of the common supplements in ASD, multivitamins, vitamin B6, magnesium, omega-3 and fatty acid, probiotics. Again, those are commonly used medication. Those all will not affect the core symptom of ASD. They can improve some of the, some research like attention, irritability, GI symptom, and we could also even, there is a potential toxicities of high dose of these medication if used unsupervised or without medical supervision. NND, and I think that is something we are hearing a lot about it on the social media. That's something we need to be really careful because, again, the proposed mechanism is that it works on the brain-gut axis. The studies has shown that there is some of the behavioral effects secondary to improving GI symptom, and this actually supplement has been studied and showed that there is low to no benefit. So it's between the orange and red category, if we will go back to the initial slide I've put. We should be really careful when we hear or we consider trying this medication. Melatonin, Dr. Turki has already discussed it in detail, so I will not really go through it. Folinic acid, and we've already heard about or had a question from the first session. So we've heard about folic acid, folate, folinic acid. So they are all different forms of vitamin B9. The folic acid that we all know that we use in like prenatal supplements, it's the inactive form and it's synthetic and it needs multiple steps to be activated to go through the folate receptor so it can cross the blood-brain barrier. The folates usually present in foods and it requires less step to go through the same receptor so it crosses blood-brain barrier. Folinic acid can be found naturally in the body cells or synthetic in the leucovorin, and then it's actually considered active or it needs minimal step so it crosses the blood-brain barrier, and usually it used another carrier other than the folate receptor. It used something called reduced folate carrier. So it bypasses these receptors so it can enter the blood-brain barrier. So how the story of folinic acid or leucovorin started? So it's not something new. So observation have been noted in late 90s, early 20s, when a pediatric neurologist noticed that there are a group of patients who have either developmental regression, seizure, some movement disorder, and they have irritability, and they did not find any metabolic or a definite diagnosis for this group. And then they've noticed that some of these groups have also some autistic features. So when they studied this group, they found that their blood folate level is normal, but the brain level was low. And when they tested them, they found something called autoantibody to those receptor I've explained earlier. So then the question brought, so could autistic children have similar issue or similar problem? So they have issue with their brain folate level, they have issue with this receptor. So when they tested autistic, they found about 70% of them, they have those autoantibody. So from here, the idea came of using the leucovorin in autistic children. So there has been an RCTs that tested, and I think here where the debate came. So children with ASD, in one of the RCTs, they found that there is a potential benefit in the expressive language. And those children who were tested and have positive autoantibody. So it was not for all autistic children. The benefit was better in children who have those autoantibody. So it was found that this medication could be potentially helpful for subgroup of autistic children, not all children. And still, the studies are still small and investigational, so we need further studies. So, and then we all heard the Trump statement, and then the American FDA, so they approved it. Even the American FDA, they said it's approved for a folate deficiency conditions. It's not all autistic. And we know autism is not equal to folate deficiency disorder. Those with folate deficiency, they could have some autistic features, but they are not the same. They are different disorders. So all these societies and academy, they came in, they said that it's not recommended for a routine use in autism, and it should be considered case by case, and can be considered for those who have those receptor positive under special care. And the evidence is still limited and insufficient to use generally in all autistic children. So other therapies that is frequently used, like the sensory integration therapy, craniosacral figure therapy, massage and deep pressure, yoga, music therapy, are all considered probably low risk. But again, their effect mainly could be on behavior, some sensory modulation, but it's not on the core symptom of ASD. So the key, again, it can improve or support emotional regulation and children engagement, but does not treat the autism. If a family wants to consider it, should be with the conventional evidence-based strategies. And that's the same also for the animal-assisted or the horseback riding strategies. Vagal nerve stimulation, and that's another thing I wanted to talk about more than the other thing, and I think most of us have heard about it. It's called التحفيز أو العلاج التحفيزي للعصب العاشر. I think that's what it says. So that's something has been also a trend on social media, and the idea is to stimulate the vagal nerve and increase the parasympathetic signal, and this should affect on emotional regulation, attention and arousal, and stress response. But the way it's promoted now on social media and between families, that it treats the core symptom of ASD, it improves the verbal and expressive language, and that's not the proposed even effect in research. So there are two ways of this stimulation. There is an implant where it's in the chest, and there is where they put an electrodes on the ear or on the neck. So the implant is approved to treat certain types of epilepsy, and that's the only thing approved in pediatric. The electrodes is still investigational, so it's not really proven to be effective for children with autism. Again, there are some studies that showed potential benefit, but we have to think that we don't know the efficacy, we don't know the long-term effect of this procedure, and I know the way it's done now, they do it even under anesthesia, so that's another risk we are exposing the child. And I know also it's very expensive, so that's another burden for the family. And the way it's promoted, and if you listen to the families, I'm not sure if it's even real or fake parent experience, like it's between day and night, from one session, the child turned from non-verbal to a verbal, and a child who's starting to communicate. So I think we really need to be careful with what we exposed ourselves and our children to. And those are the therapies to avoid, so I will not really go through them because it's proven that they have significant side effects, and it's discouraged, and it's not supposed to be not anymore used by anyone. So this graph can show, again, similar to the first slide. So you will see that the strong evidence, the one on the top, is the evidence-based therapies that we already use. So whenever a family wants to try the ICAM, they should involve their physician. They should discuss the pros and cons, benefit and side effects. They have to actually even to check the credential of the prescribing physician. So I know that, for example, vagal nerve stimulation has been prescribed by an anesthesiologist. So I'm not sure if that's the scope. I know probably giving the procedure could be within the scope of his service, but deciding which child could receive this and which child will benefit from this is not from their credentials. So that's something families need to be really aware about it. Avoid false claims. So try to avoid any therapist or any person who says that this will cure. There isn't medication till now that can cure autism, and there isn't one modalities that can treat all people or all children. So we need really to be careful. And some of them even will give false promises. I'll use this as a quote, but I've seen one of the videos for the folinic acid. It says, إذا أردت طفلك أن يحلق كالطائرة فأعطيه الفولينيك acid. This is really a false claim. We know that's still investigation, and we know that it's really unfair to give this hope to the families. It's really unfair. And we should monitor the progress carefully. And when we say monitor, we know that we can monitor that based on family history, but I think we should have a standardized way of monitoring the improvement, something measurable. We can decide if this is effective or not. And then make a transparency with the families. You need to give them all the pros and cons, all the possible benefits and possible harm, and then they can decide if they want to go through it or not. So our take-home message is that ICAM and ASD is very common and understandable. نحن دائما نقول الغريق يتعلق بقشة، صح ولا لا؟ So it's very understandable. Evidence for most intervention either يعني weak, limited, or absent. All approaches till now will probably help with behavior, GI symptoms, but not with the core symptom. And then transparency and involving family is really important. Family-centered care. Why we really care about family-centered care? Parents should be seen as the experts in dealing with their child. They should participate in all decisions. Dr. Al-Bati said that when he decides about medication, he involves the family and let them decide. And I think that's what we should do in all interventions. Should be an informed decision. So you will discuss all the available options, you will give the pros and cons, and then let the family take the decision. And services and therapies should be organized to fit the family routines, their culture, their values, their capacity, not based on a clinician schedule or a clinician preference. So ICF is one of the things that is really helpful in deciding about intervention for the families, because it's considered the body function structures, their activity, their participation and function, which is really important. And then we'll take in consideration the environmental and personal factors. And the F word actually is a translation for this ICF in a family-friendly language. So I would really recommend that you go through it and have a look for it. Thank you very much.
No time.
Our distinguished attendees, we would like to take this opportunity to reiterate that the consultation stations are open from 1:45 to 2:30 for families who wish to ask questions and meet with the specialists from this forum's speakers. The stations are in the reception area.
Well, thank you for all the speakers for the thorough information. Actually, I know this time is short and we try to cut it, but I think there is a lot to be say and told. So we will go through the questions that have been asked, and I will start. There are a lot of questions for you, Dr. Bati, a lot of questions for medications. So the first question is, a 15-year-old started developing a rash after increasing the dose of atomoxetine. Could they be related? Skin rash after increasing the dose of atomoxetine.
I think yes. If there is no other intervention, we should stop the atomoxetine and see what is going on. If the rash subsides, that means definitely it's from atomoxetine. And if it does not subside, it might be another, but most likely from atomoxetine. And it's sometimes dose related. If you increase the dose, you can get some benefit, some side effect.
There's a question also regarding melatonin. Is melatonin also recommended for ADHD kids with sleep issues?
Yes. Yeah, it's very safe to use melatonin for kids with ADHD. Either they use a stimulant, or even sometimes if they don't use a stimulant. Melatonin is very safe, and we can use it in long period without harmful effect compared to other medication.
Yeah, another question also regarding risperidone. Will the benefits gained from medication from the short period of 4 to 8 weeks continue, or they usually relapses and we need multiple courses as needed?
If the patient relapse after stop the risperidone, that means you don't treat the main reason for the symptom. You just mask it with risperidone. And when the child stop risperidone, they will relapse. Not because you stop the risperidone, because you don't treat the main cause of the irritability. I will give you an example. If the child has irritability and aggressive behavior secondary to sensory issue, and you don't treat it with occupational therapy or sensory integration therapy, if you give the child risperidone, he or she will respond from the day one without OT or sensory. But once you stop the risperidone, the child will relapse. Not because of risperidone, because you don't treat the primary cause of his issue. Another example, child start to be very irritable. We give risperidone, it's calmed the child down. Once we stop it, he or she get relapse. And later we discover that the child has foreign body in his nose and he cannot express it, because we don't think that there's some organic cause for irritability. Severe constipation, headache, otitis media, UTI in girls. So please don't blame risperidone. Miskeen risperidone. And we believe إنه هو السبب. لا. Another reason, if you keep the child on long period of risperidone, then by sudden reason, we don't know, you try خلاص ملينا من الريسبيريدون, we want to stop it. طبيعي أول الأيام يصير فيه relapse, لأن الطفل almost you do for them chemical restraint. You do for them chemical restraint. فأكيد إنك مجرد إنك you relieve restraint بيكون عندنا rebound effect. Give them 5 to 7 days الأمور تصير طيبة. فأنا أقول للأهل if there is no good justification to keep the child risperidone, taper it gradually, ما راح تحسون بشيء. وعلى أسوأ سيناريو if you want to stop it sudden, أول 3-5 أيام بيكون الوضع difficult, we need a couple of Benadryl and أشياء بسيطة بعدين تصير الحياة جميلة. لكن it's not safe to keep it a long period.
Thank you very much, Dr. Bati. Now for Dr. Ayat, I think there is a question for folinic acid. Are the commercial folinic acid products beneficial? And how to respond to families wanting to start it regardless, as it's the only vitamin with no major risk of toxicity?
So the available commercial formulas actually has this very tiny small dose. So the dose that has been investigated, it's about 2 milligram per kg per day and to a maximum 50 milligrams. So what I've seen on the commercial, it's 0.5 microgram or something. It's very tiny. So it's not the investigational dose. And how should we respond? We will say it's still investigational medication that is considered for a subgroup of people who have a presentation or the diagnosis of folate deficiency and have the autoantibody until the research proven something else. So it's still an investigational medication.
We can conclude our session, and thank you for the speakers, and thank you for you. If there is any more questions that we are not able, there is no time to answer it, we can ask us later. Thank you very much.
And now we proceed to the third scientific session of the day, addressing transition and lifespan support. This session showcases Ms. Al-Jawhar Al-Shaiji and Dr. Naif Al-Zahrani. The session will be moderated by Dr. Mohammed Al-Arabi, a rehabilitation medicines consultant at Prince Sultan Rehabilitation Complex, إيفاء, in Dmam. Please proceed to the stage whenever you are ready, doctors.
Good afternoon, everybody. Welcome to our third session titled Transition and Lifespan Support. This session will focus on strategies for physical rehabilitation, orthotics, and integrating epilepsy management into rehabilitation and transition care for children with neurodevelopmental disorders. Before we begin, please note that a dedicated link for submitting questions will be sent via SMS, or you may scan the QR code displayed on the screen. We will address these questions during the question and answers session. Our first speaker is Ms. Al-Jawhara Shayji, sorry for the mistake. Clinical Director and Quality Lead at Maria Center in Al Khobar, and a pediatric physical therapist with over 10 years of experience. She is also a certified TheraSuite practitioner. She will present on orthotics and physical rehabilitation in cerebral palsy, highlighting evidence-based strategies to improve mobility, function, and quality of life. Please join me to welcome Ms. Al-Jawhara Al-Sayji. Thank you.
السلام عليكم جميعا، يعطيكم العافية. Here. Okay. السلام عليكم، يعطيكم العافية جميعا. It's really honor to be with you in this scientific symposium. Today I will share my presentation with you. I'm talking about the evidence base that integrated model of neuromotor development for the children with the CP. And I will use, we will use the TheraSuite and Poly system to enhance the motor function. First of all, this presentation is just not methods and items we will talk about. It's something that it will make image of the therapy in the future. Okay. So we will talk about the comprehensive pediatric assessment, function, measurable goal setting, building an evidence-based treatment plan, role of the TheraSuite aligned neuromotor activities, integrate therapy session flow, function training and care over, progress measurement, motor outcome indicator, case journey and recommendation. So in this picture, we will see two kids. Both of the kids, they are crawling. But the first kid, he crawled incorrectly pattern. So he have non-reciprocal crawling. He have poor weight shifting, and he have weak trunk control, weak hip control. In this picture, after the intervention, we will have crawling, but this is crawling reciprocal. This is crawling improved weight shifting. This movement, it's become more trunk control. So what we'll do in this integration or this intervention, we will enhance the neuroplasticity with the children. We give a good quality of movement that support and reorganize the pathway for the brain. So we know the last evidence or last study that mentioned each one ratio, it has one kid between 323 children has CP. The traditional theory that have lack of neuroplasticity therapy or focusing on neuroplasticity. When we combine between the TheraSuite and Poly system and the repetition and resistant proprioception, we will give in the outcome, we will have a great outcome measure. So first of all, we have the pediatric assessment tools that we use in CP. First, we will need to assessment motor, sensory, cognitive, and the ADL for the kids. The most important assessment tools that we use in physiotherapists, GMFM, 66 and 88. We use the pediatric balance scale. We use time up and go. All these assessments we use in the first assessment. Then we need to go through the ISF, which Dr. Aya, she mentioned in her presentation. This ISF, the International Classification Function, that give us a reasoning clinical. So when I make after assessment, I need to see the patient, what the activity he needs, what the goal, what the environment, what the personal needs. So we put these all things and we establish our goals in the end. So the things that I'm working on it as a pediatric therapist, I assessment the primitive reflex. Primitive reflex is main things that we need to assess in pediatric, in early intervention. The main primitive reflex that we faced, ATNR and STNR, tonic labyrinthine, moro, and routing. If we have active primitive reflex, ATNR, we will see the patient have problem in crawling, we have problem in crossing midline, you have a problem in reaching. When we have children with STNR residual, he have problem in transitions in quadruped position to maintain. When we have tonic labyrinthine reflex remaining, we'll see he affect the trunk extension, trunk flexion. I will share this two reflex with you. If we have still active moro routing reflex, what do you think the children he will face affect his developmental? Do you have any idea? Yes, okay, let's, the moro reflex, if it's still there after 3 months, which is be integrated in 3 months, you will see the patient, he have vestibular problem and he have a head control problems. So he will have a head lag, he will have any sudden movement that I change the posture, he will have suddenly scaring. When I have routing reflex, I will face the patient, he will tilting toward one side, he open his mouth every time, because the routing is for the children that's seeking for mother milk. So when you see children 9 months and he have routing, that may be something big issue. So after that, when we do the assessment and we do the, according to ISF, we do the SMART goal. SMART goal must be specific, measurable, achievement, relevant, and time-bound. Then what we talk about today, the TheraSuit. The TheraSuit, it's a soft dynamic orthotic development in 1990, originally inspired by Russian. طبعا قصة هذه السوت استوحوها من الروس لما كانوا رواد الفضاء بيجوا وعندهم muscle atrophy بعد رحلة الفضاء فاخترعوا البنغوين سوت. بعدها جات إيزابيلا وريتشارد قالوا why not we create a suit to help the CP children to minimize the gravity effect, to give them more good alignment, good posture, and they give him more effective in the function and more stability and support. And you see that this suit, it has external resisted that activate the muscle, it correct the alignment, it give a joint proprioception, and it give the gravity less effect, so the kids, they feel themselves less weighted, and he do the function more functional. Okay, how we start this session? Session actually is take between 2 sessions to 3 sessions per day. So it's intensive rehab. It's not just once per week to have a good outcome. So we start with warm up. What's the warm up? Mobility and stretching. Then we apply the suit to activate the core and alignment. Then we do the pulley system. The pulley system, it's kindly the same the pulley system that we show in the gym. You know the pulley system in the gym that has weights and you train on it. It's the same, we apply it with the kids. And then we'll do functional play with the transfer. The transfer, like the NDT approach that we do transfer position between position to position to degramming the movement with the small, short activities. So we go here, motor learning principle. When we learn how to functional tasks as a walking, sitting, climbing, and we correct the environment, we teach the role play, parents coaching. So in conclusion, we will have enhanced the skill retention. So I'm going back again to the assessment that you use in pediatric, and it's evidence-based. We have GMFM, and it's measure 5 area. Pediatric balance scale, it has 14 items. Time ups and go, it's measure the function walking time. And we use it pre the program, then in the middle of the program, then the end of the program. So the good reason we use this kind of measure, it has minimal clinical important differences, which means this scoring that we get it's functional, it's a measurable, we can use it. It's not just statistics, not just a number in the end. So the GMFM, when you see significant between 5 to 7%, it means it has a motor function skill is gain. When you have the pediatric balance scale 3 to 5 points, it means the balance is much improved. When you have time up and go between 2 to 3 seconds faster, it means that the gait is improved. So we will see what the difference between the assessment is just give us the statistic numbers, and between this assessment, in clinical improvement, you will see small changes that represent meaningful functional improvement with the children. So one of the case I have in Maria Center, we do the GMFM before and after the treatment. I have this subspecific bilateral male, and I have subspecific unilateral female. First, the baseline GMFM, that's why I use in the first, it was 60. Then after the reassessment we do after like 2 months, he gained like 66.8, then he gained 70. So the total MCID, he improved 9.7. The spastic unilateral female, it has 25.3, then it's enhanced to 28, then 37. So here we have a like 4 months after we measure between the reassessment 1 to reassessment 2, then when we gain 12.5, which is significant, and it's a show. It's not just a number in the end. We will see the patients is improve. So the recommendation, when we have a good home program, it has adherence and the good therapeutic dose, poster session, and the good clinical choice of orthotics that give a proper biomechanism and good alignment for the kids. So in the end, we'll have a good outcome measure with these kids. In the conclusion, we need in the CP, it will be comprehensive, intensive, personalizing care. Each kids have individual plan of care, and also all these things together, we will get a good neuroplasticity and enhance the function for the kids. This is the reference, and thank you for listening.
Thank you very much, Ms. Al-Jawhara, for the nice presentation. Our next speaker is Dr. Naif Al-Zahrani, neurology and epilepsy consultant at King Fahd Specialist Hospital in Dammam. He also serves as the head of the neurophysiology department and director of epilepsy and EEG fellowship program. Dr. Zahrani will present on integrating epilepsy management into rehabilitation and transition for neurodevelopmental disorders. Please join me to welcoming Dr. Naif Zahrani.
Shukran. Thank you, Doctor, for your kind introduction. Assalamu alaikum. First of all, I would like, I'm very impressed. I'm blessed by the organizations and the welcoming and hospitality. And it's really very detailed, and you raise the standards of the conference and the Eastern regions. And believe me, this reflects a great leadership and wonderful team at IFA. Thank you. And we hope to make it an international. Really, you deserve it. And we are looking for your third symposium, inshallah, next year. So, yeah, thank you. Thank you, Allah. So I have no disclosures. I'm an adult epileptologist, so I believe in adult physicians. We need more about and to know more about neurodevelopmental disorders, and also this will help us in transition of care for those patients. They have the transition from the pediatric specialist to adult group, our team. So I would like to start with this story. I'm not sure anyone, just you could show hands, how many know about this story? Oliver McGowan story. How many? Just show hand if you know about his story. Because I just knew his story when I prepared this talk. His story, it changed the life, changed the practice of dealing with patients with neurodevelopmental disorder in the UK. And do you know who led this? His mother lead the change, which changed the practice in the UK because of his story. And they make it as a mandatory training for intellectual disability and patients with neurodevelopmental disorders among all the hospital sectors in the UK. So who is Oliver McGowan? He was born premature, 1 month before his expected date of delivery. He suffered of bacterial meningitis at 3 weeks of age. And then he had another bacterial meningitis, and the physicians told their family he could not make it. He could not survive. Despite that, he just lived with mild hemiplegia, focal epilepsy, mild learning disability, and later on diagnosed with a high functional autism. So as our populations, those disabilities, they don't limit them. Believe me, you could go and see surrounded by our lovely, they don't limit their disability. So he had this strong can-do attitude and inspired others. And he was represented the England Developmental Football Squad. He ranked third nationally in the 200-meter track event. He trained toward to become a Paralympian. So he's highly functional person. And he's friendly, kind, supportive, and humorous, as was described. So what happened to him? So first, his story started when first time he was admitted with focal seizures to the hospital. And because they could not understand what's going on with him, he felt with the seizures, he felt scared and confused. So they misinterpreted this as an anxiety, depression. So he was prescribed antidepressant medications. Despite that, their family think he has very friendly person, there is no signs of depression. So he was prescribed antidepressant medications. His seizures worsened, okay? And Despite that, they think, oh, they prescribed from antipsychotic. So when he prescribed for him antipsychotic medications, despite no psychosis, his course worsened. So antipsychotic medications later on was stopped, and he showed marked improvement, and they documented the medication's sensitivity. So Oliver has a sensitivity to antipsychotic medication. It's documented. So later on, he was readmitted. Despite the knowledge of the sensitivity, and they don't understand the previous history and the communications with the family, they re-prescribed for him again the antipsychotic. This caused him to have the oculogyric crisis, which is making his eyes rolled up as a side effect of these medications. And they believed, the physicians, the treating team, that, oh, he's just making it up. It's just a behavioral. And then 6 hours, he's been like this, and despite the family telling the physician, later, after 6 hours, they give him medication and this stopped. And he worsened his seizures up to 30 seizures a day. So during his course, he's been restrained and detained because of behavioral issue. They could not deal with his autistic behavior. They make him restrained, this will make things worse. Later on, he was readmitted again to the ICU for seizures cluster. And because he was transferred from one hospital to another, and we don't consider the family when they told them that he is sensitive to antipsychotic. And in the anticipations, because he wasn't in the ICU, he was intubated, and they planned to extubate him. They tell that we could start antipsychotic just to make his course post-extubations not worsen, and they did not involve the family to come and could handle him and just to be around him. So he was starting antipsychotic medications again, despite previously documented he is sensitive. So what happened? He developed serious complications of the antipsychotic. He became hyperthermic. He developed neotonic clonic seizures, which is first time for him. And then they did an MRI brain for him, which showed cerebral edema. So he developed a rare but fatal complications of the called neuroleptic malignant syndrome. Unfortunately, later on, he died. And they withdraw the life support for him, and he died. So this story led his mom to advocate for people with neurodevelopmental disorders and to consider the family. And then later on, at the end of my talk, we'll talk about what the lessons had been learned from his story. So seizures is not equal to epilepsy. Seizure is a transient occurrence of signs and symptoms due to excessive or hypersynchronization of brain activity. And 10% of general populations, they would experience seizures in their lifetime. Okay? So seizures is not equal to epilepsy. So you may have one seizures, but you're not epileptic. The definition of epilepsy, if you have 2 seizures more than 24 hours apart, or you have 1 seizure with the likelihood of developing another seizures more than 60% based on certain investigations, or you diagnosed with epilepsy syndrome. So epilepsy is simple, is the predispositions to have seizures. So if you have this, you'll be epileptic. And the definition of epilepsy is not only defined by epilepsy, but also defined by the neurobiologic, cognitive, psychological, and social consequences of this condition. So epilepsy management should address the cognitive, psychological comorbidities, not seizures alone. And those comorbidities are common and may often precede the onset of seizures and impact the quality of life more than seizures. And important definition here, but this is not the scope of this talk, is the definitions of developmental and epileptic encephalopathy. So epileptic encephalopathy, that means the seizures activity and the epileptiform activity lead to the developmental slowing and regression. And the developmental and epileptic encephalopathy, that means there's underlying cause, either structural or genetic, lead to both, to the epileptic and the developmental regressions, regardless of the epileptic itself, because of the underlying, How can I go back? I think, yeah, so you already know about the neurodevelopmental disorders, which is by DSM-5 is the impairment and the deficit in the core domain of language, cognition, social interaction, and motor function. So what's the percentage? So why this talk important today? Why we talk about epilepsy and neurodevelopmental disorder? Because it's common. In a patient with intellectual disability, may reach up to 45% of those patients who have epilepsy, and depend on the severity of the intellectual disability. In mild intellectual disability may reach up to 10%, and the more profound intellectual disability may reach up to 50%. What's about autism spectrum disorders? It's found to be 30% of patients with autism, they would have epilepsy, and the ADHD, children with epilepsy may become up to 65%. So it's common among patients with neurodevelopmental disorder. So this is a study done here by Dr. Al-Baradi and in Eastern region. So they assess the prevalence of seizure in children with developmental delay. So it's the study population is 200 children, and the epilepsy prevalence in global developmental delay is account for 56%. And the most common seizure type was generalized motor, and the only significant was the advanced paternal age was the most significant one in the study. This is another study done in Jeddah, and they studied all the neurodevelopmental disorders, and you could see the frequency, the percentage of each one, and the percentage of epilepsy in intellectual disability reached up to 100%. So importance of early detection and intervention for children at a high risk of developing seizures is really very important. So epilepsy and neurodevelopmental disorders, it's sometimes a dilemma. So you don't find only, so patients may have intellectual disability, they may have autism spectrum disorders, epilepsy, and underlying genetic, and they manifest with different symptomology and behavior. So it's really, when you consider the diagnosis of epilepsy in those patients, it's really a challenge because it's a complexity of assessment patients with neurodevelopmental disorders, and the misdiagnosis may reach up to 32%. So because it's different, those patients with neurodevelopmental disorder, they may have different physical conditions. They might have syncope, they might have sleep disorders, and the distortions of their feeling because of the sensory. So in epilepsy, there's something called aura, which is the early manifestations of the seizures. So sometimes patients will feel sensory changes. They will feel visual, maybe olfactory, maybe hearing. So this may be misinterpreted as hallucinations, it's not seizures. So the delay of the diagnosis may impact the patient, or the opposite way, if you diagnose him with epilepsy and he has no epilepsy, so we'll risk the anti-seizure medications. And the difficulty of communications. They cannot express themselves. So this is an issue. So how we could sort it out? So what can we do? I know it's difficult. The first thing, always when we ask our parents, could you do a video recording of this event? Let's see. Is it seizures or just a behavioral changes? EEG could help us, but we're not dependent on the EEG, because sometimes you do an EEG for a patient with epilepsy and it comes normal. With this, not exclude. And the other things which make things complicated, you may find epileptic discharge, but especially for a patient with autism spectrum disorder, they don't have epilepsy. So it depends on your clinical judgment, depends on you taking good history, and then if you're still in doubt, you do an EEG, you don't know, you still bring him to the epilepsy monitoring unit. Keep him on recording, monitor him for a couple of days, record his event, and then you could characterize better. Because if you start a patient on medications and you diagnose him with epilepsy, believe me, it's hard to change this. It's difficult. So admit patient to the epilepsy monitoring unit.
You have 2 minutes. Sorry, 2 minutes more.
Sure, I will be. So let's see this. So this is from our epilepsy monitoring unit. So he's sleeping. Okay? Woke up, changed his position. So how many of you, just show hands, if you think this is just an arousal, he's just awake, or is it something related to the seizures? So could tell is this normal behavior? Just show hand, just raise your hand. How many of you think this is a seizure? So this was because of the seizure. So imagine this patient, overnight, he's woke up multiple times because he will develop what we call a discharge, epileptic activity that woke him from sleep. So he aroused because of this. We could not know if we don't admit him to the epilepsy monitoring unit, okay? So the management of epilepsy is a complex. We're not only focusing on the seizure, epilepsy, but we considered the family. The family is the most important. We don't want them to be overwhelmed or stressed, okay? And also you consider the neurodevelopmental, you consider the cognitive dimension, and also the underlying intrinsic factor. So the definition of drug-resistant epilepsy is very important, and because your management will be different. Because if patient failed 2 anti-seizure medications, we considered him a drug-resistant epilepsy, and if you add other anti-seizure medications, the response may be just a little, but you consider those type of fibrillations with different treatment options. So usually we start with anti-seizure medications, and you select your anti-seizure medications depending on the epilepsy type, comorbidity, psychiatric comorbidities, and overall risk factors. And the non-pharmacological treatment, we could consider epilepsy surgery. If patient has a focal seizure and you could resect, despite even if there's intellectual disability. And also, you could consider the FNS. I agreed with Doctora. She mentioned that it may also improve the attention and improve the seizure frequency. Corpus callosotomy for patients with drop attack, so you could do this. And helmet is really important, okay? And amazed with Bari, I saw the helmet they've been doing here. It's really very cost-effective for our population. And also important rescue medication. You should discuss with the patients about rescue medications. I'll just skip this. And so what we have learned from Mr. Oliver McGowan's story is he's only one. He's one of the hundreds of patients with neurodevelopmental disorders died prematurely for different causes. So the most important thing is ask, listen, do. So you need to ask people with the disability, their families, okay, cares for their opinion and concern about their treatment, and listen to all involved and show respect with those opinions and concern, and do something about it and work with them, okay? So put people at the heart of decision making and respect their point of view, and don't make decision without them. So his death was avoidable. Just listen to your patients, get them involved in the care, and discuss with them, and don't ignore them. Because, believe me, the one who knows better the patient is their family. So this is just a passport that is really good if any patient with neurodevelopmental disorder carry. It's just passport for his history, what he likes, things that he doesn't like, and thank you.
Thank you, Dr. Naif, for your nice presentation. Now we have some questions. We have to try to answer to these questions. The first question is in Arabic. كيف يمكن تحقيق التكامل بين القطاع الصحي التعليمي والخدمات المجتمعية لضمان دعم شامل ومستدام خلال مراحل الانتقال المختلفة؟
هذا سؤال صعب. بس أنا أعتقد إيفاء can do this, is to how to integrate all of the sectors and in management of patients with neurodevelopmental disorder. It's really tough and needs the leadership to communicate with each other. It can be, okay? It's not something, but we need to understand the impact of this and how the outcome if we manage in a better way.
شكرا. Next question بالعربي. تعاني ابنتي من ضمور في الدماغ. بدأت تمشي في ثامنة، ومع بداية المشي بدأت ساقيها بالتقوس ولم تكن تعاني منه قبل ذلك. برأيكم ما هو السبب؟
Thank you for the question. راح أجاوب بالعربي بأن هي تسأل. طبعا احنا كل ما نبدأ طبعا في مرحلة الوقوف نواجه اللي هي وضع الوزن على المفاصل، فنبدأ نشوف شكل المفصل الفعلي أثناء الوقوف أو في أثناء المشي. لأن لما يكون الطفل في وضعية الجلوس أو في وضعية الكرولينج اللي هي الحبي، ما احنا حاطين فول ويت بيرنج على الجوينتس، فمجرد ما يبدأ يمشي الطفل راح وديتكتد هل هي الرجل في فالجس أو في فارس. بس طبعا الأخصائي الشاطر أنا يعني I feel إنه مفروض he can measure this within يعني خلال تطور الحالة، يعني راح يبان التشوهات اللي في العظم تبان أثناء مراحل تطور الحالة، وتبان وخاصة في حالة تقدم العمر. يعني أنت تتكلم عن 8 سنوات، صح الطفلة صغيرة، ولكن دائما إذا كان الطفل جانب أعمار الأشهر بعمر السنة بعمر السنتين صعب يعني، أو نقدر نقول ما راح يكون في تشوهات كثر ما نوصل إلى هذه الأعمار، ولكن بوجود الأطراف أو نقدر نقول الجبائر تدعم هذه المشاكل.
شكرا. Next question. In real clinical practice, it is difficult to apply therapeutic as it will take long time for one patient, and as private sector, cost and revenue are the thing that company look into. How much you will charge the patient, and how about the other patient when they get their appointment slot?
Okay, thank you for this question. Therasuit technique, it's a need a comprehensive center. This kind of technique we cannot apply in OBD single session between the session. It has like once per month or twice per month. Therasuit, it's need intensive. The cost, it's the same cost of any session. We not charge the patient. Therasuit session is different than hydro session or different than physical therapy session. It's a program in the end. So we believe in Maria Center, we set a program that fit for the patient needs, not according to the cost or the beneficence of the sectors. We're looking for the patient-centered care, family-centered care, and we believe this kind of patient that come to Maria Center, they're looking for a comprehensive, intensive program. Thank you.
Thank you. There is another question in Arabic. البرنامج الفعلي للبدلة الفضائية مدته 6 أسابيع ويتطلب ما يقارب 3 ساعات يوميا نظرا للحاجة إلى وقت كاف لارتدائها وخلعها، يعني it takes time. وفي حال استخدامها في المركز هل تعد النتائج المتوقعة يعني مبررة للوقت الذي نستعمله والسعر الجلسة؟
شكرا لهذا السؤال. طبعا مثل ما أنا تفضلت بالبداية، هو بروجرام يعتمد على 2 إلى 3 ساعات. طبعا احنا we not apply Therasuit 3 hours. It will make muscle fatigue in the end. هي البروجرام يعتمد على preparation، مثل ما بديت أنا warm up Therasuit apply، بعدين راح يكون في عندنا polysystem strengthening, then we have NDT or transfer any kind of transitions activities. So هو برنامج متكامل علاج طبيعي. يعني ممكن أنا في هذه الجلسة أعطي stretching، بعدين أبدأ أعطي للطفل NDT أو DMI for example، بعدين I apply Therasuit مع one of the technique، بعدين I apply the strengthening exercise، بعدين I do خلاص I cool down the session، then I do hydrotherapy. So ما الفكرة مش إنه الثيراسوت تلبس 3 ساعات أو 2 ساعات، الفكرة إنه البروجرام حق الثيراسوت لازم يكون متكامل من الستارت اب تو ذا اند اب. مو مفروض إنه أنا آخذ الثيراسوت في individual session. الاوتكم yes it has a good outcome لما تشتغل as a multidisciplinary team approach. الواحد لما بيشتغل individual ما راح يعطي good result. احنا في ارجع وامثل في المنشأة اللي احنا نعمل فيها مركز ماريا، نعمل as a multidisciplinary team. انا كاخصائيه ممارسه للثيراسوت I apply the Therasuit، يكون في اخصائي قبلي he do the stretching and strengthening. الجلسه الثالثه للطفل تكون hydrotherapy مع اخصائي ثالث. في الاخير انا كل المدارس هذه تنوعت، كل المالتي ديسبلينري عمل على اعطاء what the benefit للطفل. طبعا كل واحد جاينا من مدرسة، كل واحد عنده strengthening point في الممارسات حقته، فإحنا نؤمن إنه الطفل الواحد ما راح ياخذ 3 hours أو 2 hours the same therapist، لازم يتنقل بين الأخصائيين عشان ياخذ البنفيتس وياخذ الفائدة من كل approach. يعطيكم العافية.
فيه سؤال لزميلنا. Which type of seizure is considered to be high risk with the physical activities?
Any seizures that could impair a level of consciousness is considered high risk, especially those cases with generalized epilepsy. Those is a high risk. But the patient with focal aware seizures, it's a lower risk.
Thank you. Do we have time to continue questions? Or because there are still 2 more questions? No, we don't have time. Thank you very much. We will end this session. Thank you for the speakers and thank you for the audience.
Our esteemed attendees, we would like to remind you that the consultation stations are still open for the families who wish to ask questions and meet with Dr. Turki al-Bidli, Dr. Abdullah al-Bura'i, Dr. Abdullah al-Bahrani, and Dr. Sara Silsila and Dr. Faisal al-Qurashi. The stations are in the reception area. But now we have the fourth and final scientific sessions for the day, dedicated to systemic and policy level perspectives. The session presents contributions from Dr. Salih al-Salihi, Dr. Abdulaziz al-Tuwajri, and Dr. Abdullah al-Bura'i. The session will be jointly moderated by Dr. Faisal al-Qurashi, a developmental pediatric consultant at the King Fahd University Hospital in Khubar, and Mr. Dhari al-Mbayid, the head of the Prosthetics and Orthotics Department at the Prince Sultan Rehabilitation Complex, إيفاء in Damam.
السلام عليكم ورحمة الله وبركاته. حياكم الله جميعا. Welcome to our fourth session entitled as Systematic and Policy Level Perspectives. This session will focus on cross-sector collaboration, policies and funding for neurodevelopmental disorders and its services, as well as emerging public health issues related to prematurity and IVF babies. Before we begin, please note that we have a dedicated link for submitting questions that will be sent via SMS, and also you may scan the QR code displayed on the screen. We will address these questions during the Q&A session at the end of this respected session. And let's start. It's my overly pleasure to introduce one of my mentors, Dr. Salih al-Salihi, a consultant, developmental behavioral pediatrician, and the head of the growth and behavioral unit at King Fahd Medical City in Riyadh. He's actively involved in research and professional initiatives aimed at improving the diagnosis, research and professional initiatives aimed at improving the diagnosis, management, and support of children with neurodevelopmental disorders and challenges. He will present a cross-sector collaboration between health, education, and social care, sharing strategies to create integrated support systems for children with neurodevelopmental disabilities. Please join me in welcoming Dr. Salih al-Salihi.
Okay. بسم الله الرحمن الرحيم والصلاة والسلام سيدنا محمد وعلى آله وصحبه أجمعين. Good afternoon, everyone, and thank you for the kind invitation to contribute to this very exciting event. And thanks for the organizers for very well organization. Also, this is very important topic for me since I've been in the field for a very long time. We started at the early 20s to find ways to find solutions for people with developmental problems and their families in Saudi Arabia, because the focus was very long time on specific disorders and management through a specific specialty, and then people go home without looking into the outcomes and the cost, short and long cost on the community and families. Do I have a clicker? So I'll start with two cases that we face as physicians very commonly. One case, we diagnosed a child with autism. He needs all the services. He was sent to Ministry of Education with a medical report. The parents came, take the report, went to the social services office. They said, well, we cannot provide anything, we're sorry. You go to the education system, because the IQ is 65. So the father took the paper, again, driving in Riyadh, traffic, came back to our hospital, said, well, please either change the IQ to 50 or send me a report to education. We said we cannot change the IQ, but we'll give you another report for the Ministry of Education. So he took the report for Ministry of Education, and the Ministry of Education, well, and follow-up, they said he told them, yeah, it's better for your child to go to social affairs, but if you insist, we'll give you tickets for special education in one of the schools that they have. So this is, it doesn't take place in one day. It takes weeks for this coordination process to take time. And this is the cause is in the family and the child, and the families work as, the mediator, the transporter, whatever, for this kind of care. The second case, and this is a very common case, is that we have a child, we treated him until the age of 18 since we are pediatricians, and they said, well, we send a referral to adult psychiatry. The father came back, said they cannot receive us, they don't know how to deal with the child with autism, so should go back, continue pediatrics. We sent him to adult neurologist. They said we cannot take care of him. So even we have, as pediatricians, we stuck with children to the age of 27, 28, maybe 30, dealing with their condition because there is no adult services for them in the transitional care system that we should have. So the other one is, the first case is government and external coordination system between health sector, education, and social affairs, which have a big failure. And the second case is internal. In the organization itself, there is no coordination and integration of services between the pediatric and the adult to take care of the children. So it's a common struggle that we have. So I'll speak about a few things like some introduction, and then the sector collaboration, the current status, and the foundation for collaboration, and ways of collaboration and patient-centered care, and we'll conclude. So, in Saudi Arabia, physical disability, as you may know, language problems, social skills problems, sensory and functional, cognitive behavioral education problems is very common. We have lots of studies that say we have, disability rate very high, and it's comparable to the international communities, and because of have some relative marriages and consanguinity system, we have more people with disability and in Saudi Arabia than probably many of the Western countries. So it's a very common condition. We see them, and I bet most of the people have somebody, family or family member or family friend or one of their close circles who have a child with disability who needs proper care. So the service required are a lot. Community awareness and preventive care, this is a service. It's not just something that we talk, it should be organized, it has evidence, it has scientific rationale, it has some methods that are scientifically sound and should be implemented. And what we have is very scattered initiatives from a center here or some program there or a private clinic there, etc. There is no proper national community awareness and preventive care that should work on either, even speaking about strong screening activities and in different conditions. Diagnosis, we know Saudi Arabia, we have significant shortage, especially in the peripheral sites. With people who do, reach out clinics in the north or south or other places, they found there's significant deficiency of people for the diagnosis. And we've seen children diagnosed at the age of 12, 13, 14, and maybe 15 with autism, which is way above the recommended age for proper therapy and intervention. Most of these people, lost the opportunities to function normally, and they just need some basic life care skills management. Assessment and clinical profiling is again another problem. How many clinical child psychologists in Saudi Arabia who have proper training and who are well educated about the psychometric tools? What do they need? We have seen, services built on junior psychologists who just finished their school, and they are giving reports and recommendations to families, which is a problem that need to be addressed. So this is, it goes on not only for psychology, but other disciplines. We don't have the proper structure and system to make sure that the assessment is done by senior individual who has, thorough training and certified credentials to do the assessments. Medical rehabilitation in terms of speech therapy, occupational therapy, and others, again, and physiotherapy also. Behavioral therapies, people who are in psychiatry and more into advanced psychology, they know what CBT means. It's cognitive behavioral therapy, and it's not a course of 1 week or attending a conference and then can become a CBT therapist. It's, the people need to have training and certification minimum of 1 year to 2 years in some of the countries in the US and other places. So you need really to have a background and then proper training to be able to deliver cognitive behavioral therapy. It's manipulative system, where you can work with the brain's minds and ideas and how to engage. Unfortunately, again, we see junior people saying we do CBT therapy, and people, clinic put this as one of the lists of their services. They provide CBT. But the problem is that the alternative does not exist, which is properly trained people who can do CBT. We don't have so many people who do CBT. If you count them in Saudi Arabia, it's maybe probably less than 5 people who are very well trained and certified to do CBT, which is significant shortage and deficiency in Saudi Arabia, not only for disability, children with disability, for people with other behavioral problems and with eating disorders and others. Educational system, again, the struggle for people to get proper educational system if they have a child with disability, either especially autism, and the system is significantly impaired, I would say, to deal with the volume of people with disability that we have. Adaptive skills and acquisition and training and vocational training also. People maybe in this province lucky to have center like this and other places where there is vocational training, there is sport activities, there is daily life skill training for different age levels for people, but it's not systemized and it's not all over the country. And also caregiving and respite care. Yesterday I got one family in the clinic. He said, do you have the service that I can keep my child with you for 3 days only? He had a child with autism with moderate to severe impairment. I said, well, I'm sorry, we don't have this kind of service. We don't have this kind of service. I hope that one day we will have it. So families need a break, sometime. They need to have, a few days vacation. They need to do some kind of, or to do some work that they need to do somewhere else and need someone to help them with keeping the child for a few days. And in some countries it's legalized and there is policies for services to provide this kind of service. And, unfortunately we don't have in Saudi Arabia. So, so now because of the problems that we have, that we have parents with reports going around shopping for services or begging for services in so many situations. We have now, as a result of poor coordination system, we have poor outcomes. Families are not happy, very expensive service and long-term services. We have so many people, adult now, they lost the chance to get infancy or an early childhood services. We have, disruptive, child and disturbing the whole family system because of disruptive system that we have not providing proper care for these children. Out of school, so many people are not at school, at home, locked, and this is because of a problem, and there is lots of people who are dysfunctional, and most of the international disease classification, functionality is one major criteria for diagnosis. If the individual is functional, that means he doesn't have disorder, but most of those people are dysfunctional. So we have significant problem. So the foundation for care, again, is policy, 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 policy. We don't have policy, unfortunately, in Saudi Arabia yet. If anybody knows a policy that I haven't seen or it's not public, please let us know. But so to my knowledge, we don't have a policy that mandate cross-sectional coordination between people to go ahead and do it. So without policy, people don't have the drive or probably the incentive to go and do the coordination system, which is a significant concern that we have. Also, service infrastructure, it's very variable. Some places like this, mashallah, you have very nice infrastructure. نحسدكم عليه, inshallah, good. Hopefully much better. So, and others, they don't have any infrastructure. They don't have, space, equipment, staff, etc. Professional communication infrastructure, how do you communicate? WhatsApp or SMS? Or is there any platform with list of people who you can address if you have a medical concern or if you have educational concern? It's not existing. Professional attitudes towards collaboration across. As you know, physicians, most of the time we barely have time to say to the patient, this is the diagnosis, the prescription, go home. We don't have time to, I would say, speaking generically about physicians, to sit and coordinate and call the psychologists or call others to do proper coordination for care. And this goes for others. People get busy in their own business, they forget about coordinating, and they are not in the mood, I would say, chronically, to do some coordination and chatting with other people for these cases. The environments, are they promotive? Some people said, well, my boss said, don't call anyone. Don't just give them the report and let them go, So sometimes organizations are the problem. It's not the individuals, their system, their and the organization that preventing them from going across the road and doing the extra step to go ahead and coordinate with others for this children care. Family engagement, it's a problem. We have seen reports of people getting the diagnosis and going home in 15 minutes for the first case. Parents don't know anything about the child. Parents have no knowledge about what to do next and what's the condition, why this child has this condition. So we are not engaging from zero time in the process. And this needs to be changed, I think. Case management system, we don't have case management system in Saudi Arabia for multi-sector or cross-sectional sectoral coordination. And this should take place because we are all spending from the same pocket. We all take money from the government, but we're wasting this money unnecessarily for, wasted time for people and eventually poor outcomes that we have. So these are significant changes and foundations that does not exist so far or exist in a weak manner that need to be addressed in a very high level. So ways of collaboration, this is the best model if you have transdisciplinary collaboration system where there is a condition, everybody sits together, same place, same time, agree in therapeutic, and everybody execute the plan that they have. And this is typical in medical conditions, like for example, cholecystectomy, عمليات المرارة ولا الزايدة or whatever. There is a clear pathway. There is ER physician, there is anesthesiologist, there is physician, surgeon. This will, different people work for the same patient, for the same diagnosis, make sure the result is done, and then it goes away. The patients will be discharged and gone. This is very expensive, and usually demands lots of efforts, and people has to be around most of the time. Interdisciplinary, again, a group of professionals work to share their knowledge, to create unified holistic plan and to improve outcomes. And there has to be communication properly. They don't need to be at the same place or different than the clinical pathway, but it's more comprehensive, and people integrate their services, especially, for example, nurse and physician. They integrate their services to provide care for the patient. If a physician, most of the time in our modern age, cannot work without the nurse, and the nurse cannot work without physician. So if they integrate their care, the outcome is patient care, he goes, patients get treated and go. This is a very successful model working in hospitals and has been tested for the last 100 years, and it's very effective. If we can have this similar system for people with disability, and we make sure that we integrate our proper services individually, share our expertise and knowledge to care for the same individual, probably with proper communication, this is going to be very useful. The third one is multidisciplinary, where we have people in different sites. You send the patient, so a group of people decided to work together, either by agreement or by default, and then they send reports and everybody works alone, but they work into a group system. This is good if there is good communication also, where people can communicate, decide to do this system, and work together and share information, share data, and share outcome. They can call each other, said, okay, what happens if the child is not improving, etc., etc., or can you increase or decrease something to improve the outcome of this patient. This is, again, a very good model if we can have it. If we cannot have the previous two, we can have this model of collaboration. I think they forget. These are not my updates. One more model that I put, which is the coordination model, where people there is somebody who coordinates services. So someone, case manager, who sits and call people, people agree that, for example, we have case managers in hospitals where they will take care of calling the physician outpatient and nursing and nutritionists and others, make sure that the care is done, and this is the cheapest way of doing it. Hopefully that can be done. I think I think it's going backwards. Thank you anyway, Anna. Okay, so all services has to be family-centered and I would say child-centered, family-friendly. People say just child-centered, family-centered. That should be child-centered and family-friendly. We're not friendly to families. Most of the people are not. Families face difficulties with us as health system. I'm finishing, but this is not finished.
It's okay.
Okay, so family we should address with them the early intervention regardless of the diagnosis. We have to tell them you don't need the diagnosis to get intervention. This is a very wrong concept that we have, that most of the communities have, that if you don't diagnose it, that means that my child is okay, you don't need the therapy. I think it needs me to go to conclusion. So family counseling is very important. We have to tell them what to expect, how to navigate in the system, and what kind of help that they need from us, and we should provide it. So in conclusion, cross-sectional collaboration is an integral part of patient care. So it's not an accessory. It's an integral, very important part of care. And actually, most of the international accreditation bodies dig into this very well. Make sure that you have proper cross-sectional collaboration. National policy must be established as basic infrastructure for collaboration, and this should be done, and utilizing technology as an AI is a necessity these days to provide case management, electronic case management system. I have submitted a proposal 8 years ago to establish electronic case management platform. Reviewed by the Saudi Health Council, they put it freezing, and then eventually lately taken by one of the NGOs, and they are finding sponsorship for it to integrate it with المنصة حقت توكلنا وما إلى ذلك, to make sure that you don't need to send the patient. So I can electronically communicate with the education system with a press of button. I can communicate with social affairs, so parents will get messages to go receive services, and instead of parents are moving around to beg for services. I hope that this can be expedited, and probably tomorrow we're discussing a national policy that should be recommendable in the Saudi Health Council for services for people with autism. Hopefully, if we can finish and agree, this is going to be one of the integral parts of the policies that should be submitted to the Royal Cabinet to agree on it. Thank you for listening.
جزيل الشكر دكتور. Our next speaker is Dr. Abdulaziz Tuwaijri, a senior health economist and director of health benefits management at the Center National Health Insurance in Riyadh. He will present on policy and funding for NDD services with a focus on coverage, accessibility, and equity, and share insight on how strategic financing frameworks can improve access to essential care of all families. Please join me in following, welcoming Dr. Abdulaziz Tuwaijri.
Thank you, everyone. It's my pleasure to be here today, and I hope I can add to this very impressive scientific program. I'm sure by the end of the day, most of you maybe get tired of the clinical information, so I'll try to change the direction a little bit to start to talk about coverage and equity. Okay, so in general, I'm sure most of you know about it. The neurological development disorder, it includes multiple diseases or multiple disorders like autism, ADHD, etc. The onset is usually happening in the early childhood, and there is conditions that it's all mostly require multidisciplinary interventions across sector. And Dr. Saleh here, he highlighted many of the gaps that usually patients will require multi-interventions, but there is a gap. There is no clear linkages and no clear pathways. So just to also highlight that those disorders is mostly among the leading cause of childhood disability globally. Unfortunately, we don't know exactly in Saudi how that impact is. And hopefully with further studies around that will show us what is the problem, or how big is the problem, and then we can act and respond to that problem. There is also, it's well known that those conditions will cause long-term consequences in education, in employment, and in social inclusion. Usually those in economics consider as indirect cost, and we don't usually capture this. In Saudi, we usually look at what is the direct cost, how much it costs us to treat that condition, but how much is the cost of preventing or improving that condition through indirect costs, that the cost of employment, the cost of presentism, absenteeism for the patient and for the caregiver. And those are missing information here in Saudi. We should also highlight, if we know that, we would know that early investments will lead to higher downstream public expenditure. If we invest early, that will save us from huge investments in the future. by improving the cases, by reducing the needs for more extensive care at later stage. Looking into the global epidemiology, and I'm sure that most of you are very aware of this, if we look at this, we would notice that those numbers is actually not far away from what we saw in Saudis. And the number is actually increasing. And those increases, most of people may consider it as a reason that there is an increase in the trend, but maybe it's another cause, which is the increase on how we are good in diagnosis. We start to capture cases early. We start to identify those people. Maybe in the past, those cases went undiagnosed, and that's why we didn't capture them. So with the improvement in diagnosis, we are actually able to catch more cases, and hopefully those cases will be catched in early stages where the interventions work best. If we look at those numbers in terms of Saudis, the estimated prevalence is not far from global estimates. Usually, the issue that we face is most of those cases is diagnosed within large cities. And that could be a reason for inequity in availability of centers. Those who live in I would say urban areas, or usually they will have the chance to be diagnosed early due to advanced hospital, etc. But in remote areas where the hospital is actually not very equipped, the specialties of the doctor, the diagnosis, etc., it's not as it was seen in Riyadh, Damam, Jeddah, etc. And those could be a leading cause for undiagnosed patients. Dr. Saleh also highlights that there is a need for a standard pathway for care. And this standard pathway is actually not only going to improve, if we look at it from two different sides, it will improve the outcome of the patient, and it will also improve or have a higher return of investments, meaning that whatever we invest in that path, the return of investment will be high due to indirect cost, specifically because the direct cost usually it will be the same, but the indirect cost it will be a very high impact. We should also note that within the Saudi there is a young population, meaning that there is a chance that we will see even more cases. However, it's the other contradict this idea is that we are experiencing in Saudi, as of the whole world, the decline of fertility rate, and that would also impact the number of cases that we will capture yearly. So taking both scenarios, we don't know up to now what we would expect as a number of new cases in the next 5 to 10 years. Is it going to be less incidence due to less fertility rate, or is it going to be higher due to higher or improvement in diagnosis? And these two scenarios need to be investigated very well. I'm sure most of you know that the majority of those cases happen in male more than female, and that will require maybe further investigation about the causes. One of the major things that I think is usually overlooked, we know, as a fact, we know that many people complain about it, but we didn't quantify it yet, which is the out-of-pocket. How much a family is paying out-of-pocket to receive the care? Not necessarily direct care, sometimes it's indirect. How much they are investing for traveling to go for healthcare facilities, how much they are investing for extra for education, how much they invest extra for social care, etc., how much of their time they spend it with their children, and those time is money and wasted. For example, it's appear in economic term, it will appear in term of absenteeism. How much of their time they had to absence from their work to stay with their children. Even if they go to work, how much of their time during the work they are actually worried about their and lost focus in work due to they're worried about their children. We have to look, when we look at the service delivery, we have to look at 4 major areas, which I would consider it as a delivery landscape. There is the healthcare, which is usually coming from MOH, coming from hospitals, university, hospitals, and private sectors. The other part is education, which is usually Ministry of Education, but we have to highlight here that their education is not as a regular education. It will require some specialized education and some specific programs for those type of patients. We have also some services delivered through NGO and social sectors, and those usually charitable and unsustainable. We need to think more of how we can shift this type of work to be more sustainable, more profitable to them, so they can also include more beneficiaries. When we looked at how usually the service is accessible, we find out, there's studies found out that only 31% of children have access to nearby specialized centers. Most of the services concentrated, I say, in Riyadh, Jeddah, Damam. However, peripheral region facing long time to access the service, and there is a supply side capacity constraints, which is dominant. There is a very clear urban, rural disparities, and almost 72% they have, of these areas, they have lack of specialized schools in their region, which will also impact the accessibility to the services. Let's move to how usually those services is financing. There is predominantly public financing through MOH, Ministry of Education, and Social Ministry of Human Resources and Social Development. And usually that's supplemented by private and charitable funding. However, it is highly fragmented, purchasing and budgeting. In insurance coverage, there is a gap. Usually the coverage is varied significantly across insurer, while the issue that while CHI usually bought a minimum or essential benefits package, they usually classify those kind of disorders under the bucket of mental care, and those are that package is usually limited to 50,000, which is not enough to cover all kind of services that is required. Also doesn't include different type of services that is needed rather than the medical services. It doesn't cover any educational, doesn't cover any social care as well. So that's happened because there is a lack of pool funding for long-term therapy. There is a weak coordination between payers and providers, and that's things I think it's need to be worked on. And there is a minimal use of outcome-based payments model. One of the things that will encourage both providers and payers and will encourage a better coordination of care, better clear pathways, is that if we link the payments to outcomes, meaning that if someone is delivering a service, but it's only part of the pathway, it means it will not reach the expected outcome unless it's completing all the pieces. And that's why the payer will not pay until they receive that outcome. Using those kind of models, payment model, I think it will be very helpful in those cases and will encourage more of coordination and care pathway. If we looked at the benchmark countries, in UK, for example, they have universal access to diagnosis and therapies. They have also access to education, healthcare plan, and they have a strong intersectorial governance. In Australia, I think also they have very strong program as well, targeting those population. And this program is mostly focusing on in early interventions. And they have national data infrastructure to support the planning. And that's one of the weakest points, I think, that we are facing in Saudi. In Canada, there is community-based delivery models. They have disability funding programs, and they emphasize on inclusion of education, because without education, the target outcome will not be as expected or as we hoped for. Here, I think what we need, or the lesson learned from those countries, is that we need a unified governance. We need a guaranteed entitlements, even for the investors who want to invest in the delivery of healthcare. If they find out that they have a guaranteed coverage, they will start to invest more. And we have one of those examples happen in one of the cases where we start to fund and cover long-term care facilities. The investments in those areas are increasing significantly in Saudi. We need also to have more data-driven planning, and these features remain, however, all of these three features remain underdeveloped in Saudi Arabia, and hopefully it will be in the next year agenda. Here, I try to summarize what is required for more of a strategical approach to address the long-term and chronic nature of those conditions. We need to improve the healthcare access, and that can happen through mandatory coverage, whether it is governmental coverage or private sector coverage. We need more social investments, and those will have more social impacts bond. We need long-term stabilities, like in the Waqf and charitable organization. They need more stabilities to ensure that their funding and their support to those systems are sustainable. And we need more research and funded research, basically. We need more fund to those research to understand more how big is the problem and what is intervention that can work with us, and what is the return of investments of those interventions. As a summary, I would like to highlight three major points. We need more of equity analysis to understand how big is the gap between countries, between areas and regions within the Saudis. We might face only what we saw in Damam or in Riyadh or in Jeddah, but do we know how big is the problem in a remote area? And that will require also further analysis and further research. We need also to work on policies to overcome fragmented financing system. Policy also to look at early intervention and how impact is it and how we can enforce it. A policy to improve data gap and improve and without data we cannot improve the accountability of each entity that's providing the care. For future step, I think it is needed to have a registry. It will support most of our work in this area. We need to develop a standardized care pathways, and that will be, and I think Dr. Saleh mentioned something about it within Saudi Health Council. We need also to strengthen workforce planning. We know today that workforce is basically, or people go to that area because they love what they want to do, or they find it, for example, profitable. But we want to exceed that. We want to have a systematic planning, whereas the government, the country will encourage people to go more in that direction to fill the gap of the services. Also, we need to conduct more of cost effectiveness and equity studies to find out how big is the problem in our economy and what is the return of investment of each of that interventions. With that, I think I reach to the end of my presentation. Thank you very much.
Thank you, Mr. Abdulaziz, for shedding light on funding strategies for children who are suffering from neurodevelopmental disorders. I will definitely look biased in presenting our next speaker. He's a very close colleague and friend of mine. Our final speaker for this session is Dr. Abdullah Al-Bur'i. Dr. Abdullah is a neonatologist and also the head of neonatal intensive care unit at King Fahd Hospital of the University in Al-Khobar. He will deliver a highlight talk on premature and IVF babies as an emerging public health issue, discussing the clinical and public health implications. Please join me in welcoming Dr. Abdullah Al-Bur'i.
في البداية أحب أشكر اللجنة المنظمة على دعوتهم الكريمة وعلى الاميزنج arrangement اللي صار يعني ما شاء الله. I organized the hot topic conference in pediatric for the last 10 years, but what I saw was really amazing here. So I'm really proud of it. This is the first step. So my topic today will be about, as you can see, prematurity. Just to be sure. Okay. So we're going to talk today about the intersection between prematurity and IVF in Saudi Arabia, detailing epidemiology, long-term neurodevelopmental problems, and also policy for these things. We're going to compare what we have with the global data and any other initiative in other countries, such as follow-up policies. So, nearly around 15 million every year we have a preterm baby is born. And prematurity is the leading cause of mortality in children less than 5 years globally. This graph will show you that the prematurity prevalence, it changes from area to area. It can be as low as 4 to 5%, as in Croatia, Latvia, and some Scandinavian country, and it can be as much as 16%, such as Indian subcontinent and sub-Sahara region. Not only the prevalence, also the mortality. For example, in North America, the mortality rate is around 1.5%. In the Middle East and North Africa is 6.7%, while in sub-Sahara is 9%, which is 6 times the North American or high-income countries. What about Saudi Arabia? Unfortunately, we don't have a specific data or from Ministry of Health to have the exact number of the prevalence of prematurity in Saudi Arabia. However, the latest and most comprehensive study was done by Dr. Iman Al-Maghasla. She did a systematic review and meta-analysis of several studies, and the conclusion was our prevalence is 7.89 per 100 live births. The only study that happened in the Eastern Province was done by Dr. Faisal Qurashi 12 years ago, and we have similar number, which are around 7.5%. So if you want to calculate, the estimated delivery annually is 500,000. And if you have this number as a preterm baby, that means we have at least 40,000 preterm delivery per year. If you are dealing with preschool kids, so over 5 years, you're going to have around 200,000 preterm baby, which is a big number for Saudi Arabia. So what do we mean by prematurity? Some of you might not be familiar. So we define prematurity, any birth below 37 weeks of life. But some will say, would you consider 25 weeks of gestation similar to 35 weeks, for example? Definitely no. That's why, I hope it's clear, we have divided prematurity to extreme preterm from 24 weeks to 28 weeks. Usually these babies will stay in the NICU, will need mechanical support for ventilation, will need nutrition through IV, and usually going to stay in the NICU for 3 to 4 months. While the very preterm from 28 to 32 weeks, still they need close monitoring, but usually they don't need that intensive support. And luckily, moderate preterm and late preterm from 32 week till 37 week, they are the majority, which around 85% of preterms in the community. This graph will show us the survival rate. We can see here starting from 24 weeks, which is around 55%, and there is very steep progress up to 28 weeks, which is 94% of survival rate. After 28 weeks, almost it is plateau. The area between 22 and 24, they call it the age of viability. It's a controversial issue. Some countries like Scandinavia, Sweden, specifically Japan, Canada, they will resuscitate 22-weeker or 23-weekers after discussing with the parents. But still, the survival rate is not that optimal. It's only 11% in 22-weeker. Prematurity has a lot of risk factors and causes. You cannot pinpoint to one reason at all. I will not go through them, but I'm going to highlight some of them. Multiple gestation. And we know that multiple gestation can be spontaneous or correlated to IVF pregnancy. The other reason, older maternal age, especially for more than 35 years. Cigarette smoking, vape, shisha, obesity, and maternal stress. All of these factors are present in our community in a higher level, and they are increasing with time. Marital age is increasing than before. So a lot of ladies, 35 weeks, and still they are conceiving. Smoking, especially the vapes, is increasing, unfortunately, in the female society. Maternal stress, a lot of ladies are working, driving, doing multiple jobs, and these all are stressor on them. Also, I didn't mention short pregnancy interval. Anything below 18 months will increase the risk of pregnancy. If the lady is planning to first pregnancy at 35 weeks, so she might try to have frequent kids in a short interval, which will increase the risk of prematurity. Now we'll go to the other part of IVF. So the first IVF-born baby was in 1978 in UK. And since that time, it is estimated that we have around 2% of every year delivery is related to assisted reproductive technology, mainly the IVF. And since that time, we have 8 million baby was born through this technology. In Saudi Arabia, the first IVF center was in 1986. And after 1 year, the first baby was born in July 1987. By 2007, we have more than 23 centers, and by 2018, it is estimated more than 35 centers and more than 20,000 cycles per year. And this data is almost 7 years ago, so I believe the number is more and more. So what's the problem with IVF? Unfortunately, we don't have a national embryo transfer limit that we can implement it to the clinics. So a lot of clinics are transferring 2 or 3 embryos. Well, the maximum should be 3 embryos, but they're transferring 2 to 3 embryos most of the times. And the consequence of that we have a lot of preterm babies are delivered due to multiple gestation, and our NICU is suffering a lot from IVF babies. So one of the solutions for this problem is elective single embryo transfer. A lot of European countries, including Turkey, they have a lot of initiatives. For example, in Turkey in 2010, they tried to do elective embryo transfer initiative. So they will transfer 1 embryo for mothers, for mothers less than 35 years who have their first cycle. And it found that it reduced the multiple gestation. And it found it reduced the multiple gestation rate from 23% down to 5% with keeping acceptable pregnancy rate. So this technique or this policy, it might need to be implemented in our country. Okay, I'm going to talk quickly about some of the problems that premature baby are going to face in ICU. They might have intraventricular hemorrhage, brain bleeding. Sometimes they'll have leukomalacia in the white matter. Sometimes they'll have retinopathy of prematurity. All these problems will affect their neurodevelopment later on. So it is well documented that children born preterm have higher risk of neurodevelopment impairment than full-term siblings. And this graph, it shows the moderate to severe impairment by percentage. Most of in our country, we're not dealing with 22 to 23 weeker, but if you see 24 weeker, 42% will have moderate to severe impairment. If you compare it to almost less than 6% from 28 weeks and beyond. So this period, which is the severe prematurity, is very critical, and a lot of babies, we're going to face them in the developmental sector. If you want to compare a lot of countries and low and middle income countries, there is a recent meta-analysis of 73,000 preterm child in 12 countries. The overall neurodevelopmental impairment was 16% of cases, with 8 to 13% who have a delay in significant in certain domains, for example, cognitive, motor, or language. So this number covering all preterm babies. While in high-income countries such as Canada, they have a study and kids less than 29 weeks, and the results showed 17% have significant neurodevelopmental impairment, and 29%, almost one-third, will have mild to moderate impairment. In Saudi Arabia, we have only one single study. It's done in National Guard Hospital in Jeddah by Dr. Mohammed Al-Hindi. So they use agents ASK questionnaire. They did a single center study in Jeddah for very low birth infant at 18 to 24 months, and the outcome showed 42.6 showed neurodevelopmental delay for this very preterm babies. So what about babies who conceive with IVF? Are we expecting different neurological outcome or neurodevelopmental outcome? Research indicates that IVF per se is not a determinant of worse neurodevelopmental outcome when confounding factors are controlled. But because IVF is linked with multiple pregnancy, these babies are going to born prematurely, they will have some neurological development implication. We have one study by Dr. Al-Hadrul in Riyadh. He compared the school performance for kids between the age of 8 to 16 years. Half of them were conceived by IVF, and half of them were conceived naturally. And the outcome, they have no significant difference in long-term outcome or academic performance between the IVF and spontaneous conception group. We know that early intervention and diagnosis is important to improve the outcome for these babies. And this cannot be achieved without a structured follow-up program. This program, you need to have pediatrician, you need to have pediatric rehabilitation consultant, you need to have physiotherapist, occupational therapist, speech therapist, psychologist, all of these to have a proper program. And unfortunately, until now, we don't have such a program like that in Saudi Arabia. In the United Kingdom, the NICE guidelines, they say all babies born below 30 weeks should have coordinated follow-up. And everyone born below 28 weeks should have, they have developmental assessment at 2 years and 4 years of age. In Canada, they have similar figures for kids less than 29 weeks or 1.5 kg. And as I mentioned, in Saudi Arabia, we don't have a formal follow-up program. We have something called high-risk clinic in tertiary hospitals, like what we do in our hospital and other hospitals in the area. We are not, to be frank, we're not the experts in that field, but we try to catch early developmental delays we try to refer the patient. We struggle that we don't have people to refer. In our hospital, we don't have pediatric speech pathologists. We don't have occupational therapists. We don't have rehabilitation consultant. So sometimes, even if you want to refer, you will have time. طيب. So this will be my last slide, talking about policy implication and recommendation. So the first point, we need to strengthen prevention of prematurity. Prevention is the goal. So the Ministry of Health, they should continue their initiative on maternal outcomes for reducing early pregnancy, early delivery, such as, for example, try to control chronic diseases in pregnancy, try to reduce infectious diseases, and cessation programs. Another important point is optimizing IVF practice. It is by controlling IVF centers and ask them to adhere to the international best practice for embryo transfer. I believe we need to have a policy in Saudi Arabia for a single embryo transfer. It shouldn't be totally mandatory, but we should consider for younger mothers, and we need to educate them that to have one healthy child is better than to having two twins who are born prematurely and have a lot of complications. The third point, we have at the moment, Saudi Arabia has tried and progressed significantly in NICU beds and in neonatologist education and training. However, we have to increase our capacity in post-follow-up care, especially by increasing the number of developmental clinic, early intervention services, and also to increase pediatric rehabilitation centers, which we lack at the moment. And not to forget also, we need to have a policy for this age group, especially who are born less than 32 weeks, to have a structured follow-up so we will not miss such a cases. But again, if you don't have the infrastructure, the enough number of clinics, you might not perform properly in this initiative. Dr. Al-Salhi already talked about intersectoral support between health and education. We need to find a mechanism where we can inform the school that this child might have developmental concern, so they can have a tailored educational plan for such a children. And family support and awareness. Policymakers should always consider family needs in their plan. Other thing, we need a lot of parents of premature babies and IVF babies have been gone through a lot of stressful situation. They need psychological support, the parents and not the kids. They might need social service, and they might need to know how to deal with their child's need. They might have a neurodisabled child who have certain needs. They need to be trained how to address it. And finally, the most important step is research and data. Continuous research will help us to guide the policy. We need to have our own registry, for example, for IVF, for prematurity, and the outcome. So we can know what intervention is working good for these babies, for the brightness of our kids. And finally, prematurity and the rise of IVF at birth represent an emerging public health challenge in Saudi Arabia, but also an opportunity. By learning from the global best practice, investing in preventable strategies, follow-up care, the kingdom can improve in survival and the quality of life for these vulnerable babies. And thank you.
شكرا لك دكتور، يعطيك العافية. وأظن أشوف أسئلة هنا يبغى لها المديفر، بس أنا ما أدري أقدر أسألها ولا. تفضل.
At King Fahd Medical City, we established high-risk neonatal follow-up program since 2006, I think, and it's comprehensive with rehab and everyone, and they follow children until the age of 6 years, but it's limited to the site. يعني.
في أسئلة بحاول إني أجمعها مع بعض عشان الفائدة اللي يسألون. أول شيء دكتور صالحي، في سؤال بالنسبة للإيرلي ديتكشن للمستفيد، كيف أنه من ناحية المالتي ديسبلينري والانتر ديسبلينري هذا بشكل معين من تجد على عاتق المسؤولية أنه يكون في الإيرلي ديتكشن أوف بيشنتس عشان we intervene as soon as possible.
I think the early detection has mainly three components. First, community awareness, and this is the job of everyone. Second is the policy. We have the policy now, the screening for autism at the age of two years, which is compulsory now. It was signed by the King 2022, and hopefully that people are getting their children screened at the age of 2 years when they go to vaccination clinics. And the third one, conducting the screening method, which is need collaboration between different, primary health care and hospitals, primary health cares, centers and specialists in different places, because once they have suspected case, they have to refer. Many of them get stuck. Where should we refer them? We don't have so we need to have a collaborative agreement between places, especially private sector. When they do screen and they have a child who needs more assessment, they get stuck with them and they give the parents the paper and said, go find a place to give the diagnosis. Otherwise, should have been coordinated through an multidisciplinary team approach or service level agreement that should be signed between different care players. But the screening has to be done early age so that we can capture cases and start the intervention as soon as possible.
فيعني المدارس اللي عليها العاتق المسؤولية أو البرايمري كير أو مين بالضبط المسؤول؟
So it's a primary health care system. Schools, it's surveillance. When you go to school, there is a trigger. There is child behavior, the child language issues. There are things that alert the teacher that there is a problem. From there, red flag, that they can ask the families a few questions and then ask the families to go and find physician to diagnose them. In developed systems, the school will send automatic referral to affiliated health clinic or health system where they can book the child for appointment and they can, do the proper screening. Until this happens, hopefully, that school teacher get, the courage to really highlight the red flags and ask the parents to go and get diagnosis. What happens now, actually, they kick children out of schools. They said, خلاص, go and find school الحقين التوحد or find school for disabled we don't have. We are a normal children school that we don't have integration classes. And this is, should end. I think there has to be some cross-sectoral collaboration and agreements where if you have suspicion, you send to us. That's the beauty of, for example, electronic case management, where the teachers have access to healthcare facility by referral.
عند أستاذ رنا سؤال. تفضل أستاذ.
السلام عليكم. أنا طبعا ما عندي أكسس للأسئلة المتقدمة اللي بيقدموها الجمهور through the online system. I had to raise hand for that. أول شيء بدي أشكر كل متحدثين اليوم. بس الجلسة الأخيرة دسمة كفاية إنه تخلينا نجلس أسبوع مع بعض ما نخلص. Thank you very much لكل very fruitful knowledge اللي اتقدمت. دكتور صالح طبعا معلمنا كلنا. You have said it all. كل التحديات اللي احنا صار لنا سنين في المجال unfortunately واعيين لها نعرفها. جربنا إنه إحنا نعمل تدخل لها من أكثر من زاوية، عن طريق الوعي، عن طريق التدخل التخصصي، عن طريق توفير البرامج والمبادرات، عن طريق building النتورك، عن طريق بناء الاستراتيجية. actually أنا كنت في فريق إعداد الاستراتيجية الوطنية للأشخاص من ذوي الإعاقة في وزارة الشؤون لما كانت قبل الميرج اللي حصل. We've been through many rounds وcycles لحل التحديات اللي ذكرتها، واللي كلها خلاصتها الكروس سيكتورال initiatives اللي مفترض تكون patient centered. يمكن المقترح اللي قدمته دكتور واحد أيضا من الحلول الجوهرية اللي كمان إحنا في مجمع الأمير سلطان للتأهيل باي ديزاين actually بنشتغل طبيعي في هذا الاتجاه اللي هو الهوليستيك ابروتش وال360 ابروتش كايند اوف انترفنشن. المجمع اتصمم من 30 سنة بأفيليشن مع شيكاغو ريهاب فور انستيتيوت شيكاغو انستيتيوت فور ريهابيليتيشن وواشنطن دي سي هوسبيتال فور تشيلدرن هوسبيتال. انعملت افيليشن لمده 3 سنوات، انعمل الميديكال موديل حق المجمع، اتأسست فكرة كيف انه كل الخدمات تقدم بطريقة متكاملة من فريق متعدد التخصصات، يشتغل على كيس يكون في كيس مانجر وينبني على المالتي ديسيبلينري تيم ابروتش، وتأسس على هذا الأساس in a very low profile لسنوات بنشتغل فيها، بنحسنها بنطورها. We know and we see كيف هذا الابروتش يخلق فرق في الكونتريبيوشن حقت كل الأطراف، كل الستيك هولدرز، الأهل، المتخصص، الطفل، الشخص اللي بيشتغل حتى بعيد عن الإدارة التخصصية نفسها. يعني إحنا اليوم ولله الحمد حتى الإداريين يعرفوا التأهيل. I know this approach would work. ما هو سهل، لكن ما نقدر كمان إنه إحنا نقول ناجح 100%، لأنه دائما هذا المجال قاعد يتجدد ويتغير. وعشان كده إحنا بنشتغل الآن مع الإدارة الطبية الجديدة إنه نفتح بارت تايمر كلينيك لتخصصات مختلفة عشان يكونوا معانا اون بورد في أوقات معينة بتدخلات معينة لحاجات معينة. واليوم إحنا بنفتح الدعوة هذه لكل خبراء ومتخصصين المنطقة الشرقية أولاً، وبعدين المملكة طبعاً أكيد يسعدنا، لكن we are toward إنه إحنا نقدر نلبي جزء من هذه الممكنات اللي توصلنا لهذا النوع من الخدمة. دكتور تويجري thank you very much لأنك مسكت الأذر end of the story. يعني احنا بنتكلم من السيرفيس بروفايدر لينس او برسبكتيف، وانت بتتكلم من الكفرج برسبكتيف اللي احنا حنغطي فيها مع بعض ونوصل للهدف حقها. مشروع الضمان الوطني او التأمين الوطني جديد، لسه ما عندنا المعلومات الكافية عليه. مرة شكرا للي انت قدمته وللمعلومات الغنية اللي احنا سمعناها اليوم. We are very very much interested إنه نعرف كيف ممكن إحنا نكون جزء من رحلة البرنامج بشكل ناجح، وكيف نقدر نضمن إنه المستفيدين حقونا يكونوا جزء ناجح من الداتا والمعطيات اللي يتطلبها البرنامج. Thank you very much دكتور البرعي على الطرح المميز حق ورقة العمل اللي تقدمت. أنا خفت إنكم تمشوا اليوم، سمعت في أحد مسافر اليوم، ما كنت هاين علي إنه في أحد يمشي بدون ما أشكركم، فما عندي كان سؤال، بس كنت أبغى أكد إنه إحنا مرة سعيدين بوجودكم، وطبعا بكل الأطباء اللي شاركوا من الصباح. كل حلقة كانت فيها غنى وفيها يعني إثراء معرفي جدا كبير بتنوع الموضوعات، لكن كلها اتفقت على إنها كانت غنية ومميزة. فثانك يو فيري ماتش لكم ولحضوركم ولوجودكم معنا في مجمع الأمير سلطان للتأهيل.
جزيل الشكر أستاذ رنا. بجمع الأسئلة مع بعض باراجراف واحد. في هنا هو ليس سؤال بل مجرد مداخلة، والمداخلة مبنية على سؤال متضمن داخلها، اللي هي سؤال انه الستاتستيك وايز اللي موجود، كيف عملية الإحصاء. واقدر اوجه من بعد اذنك دكتور عبد العزيز تويجري انه الإحصاء في المملكة، وايضا انه كيف أهمية التخطيط بين مؤسسات الدولة لوضع خطة كاملة للبنفيشريز المستفيدين، انه كي لا تعمل المؤسسات كجزر معزولة. كيف هذا الشيء حاصل الآن في السعودية؟ وش الجهود اللي موجودة اللي تعزز هذا الشيء؟
يعطيك العافية. طبعا يمكن أعتقد إنه في تحول كبير قاعد يصير في المملكة. Digital transformation, big digital transformation, and our shift to insurance-based system will encourage that. In the past, the way we are funding is a block budget, so we pay the provider and the provider deliver the service, and we don't have enough visualization or enough knowledge of where is this fund is going. Today, when we, or in the near future, when we shift to insurance, that will encourage more the provider to submit some sort of a claim. It's not going to be the same way as we see it in the private, but they had to submit the claims. So that kind of claims will help us to capture the data. If they find any kind of intervention, we would.
Doctor, you want to try this one?
So I think that will be very helpful. If we're gonna reimburse based on the claims, based on the data of the claims, we're gonna use those data to calculate the capitation or the risk-adjusted capitation budget that we will deliver to the cluster. Today we are doing that through the reimbursement of private sector. We pay the private sector through the claims. Whenever they submit, we evaluate, we test the claim, we identify how much it's worth, and then we decide the reimbursable rates for that. And that's basically caused a lot of data flow from private hospital to our system. And we try to unify one approach to do that through Nafis. So as of today, almost all the private sector in Saudi are linked to Nafis. Based on my understanding, National Guard now is linked to Nafis. King Faisal Specialized Hospital is linked to Nafis. I think King Fahd Medical City as well. So more of governmental sector. Capturing this data will require two things. First, submitting the right data, and before that also there is the right clinical documentation, and that's one of the gaps that we saw it here. Mostly, and I'm sorry to say that, but most of the healthcare provision, they don't write enough details in the patient file, and that's causing a problem when we want to shift that data to codes, and those codes will go to the data system. And through the data system or Nafis or whatever, we can do the analysis. That's, I think, one of the things that need to be enhanced. The other things is building the national registries for certain diseases. It will also help researchers, policymakers, investors to understand how big is the problem and act upon it.
يعطيك الف عافية. وعندنا الدكتور فيصل راح ينهي الجلسة.
يعطيك العافية الله يرضى عليك. I think most of our previous efforts were driven by للأسف non-data driven decisions. Now with the big movement or data shift towards implementing such strategies كفاءة الإنفاق, expenditure efficiency and غيرها من المؤسسات, everything is put into place. أستاذ عبد العزيز والفريق بيتحرك بطريقة that is data driven in nature. They cannot proceed with establishing any kind of financing strategies to include governmental and also private sectors without having those data. وأمانة well-established argument. للأسف some of the big number of our healthcare providers are not keen into providing good documentation. So once we have an established national registry for that, yes. So once we have an established national registry that is full of data that are related to neurodevelopmental disorders, oncology cases that need to be addressed at a national level, then we can move toward implementing and making proper decisions.
يعطيكم ألف عافية. وبكذا عندنا الفاينل كلوزنج مع أروى. تفضلي. شكرا جزيل الشكر. يعطيكم العافية.
حضورنا الكريم، بهذا نكون قد وصلنا إلى ختام جلسات اليوم الأول من ملتقى إيفاء العلمي، وقد سعدنا بكم وبما قدمه المتحدثون من معارف وخبرات في مجال النمو العصبي. نشكر لكم حضوركم والتزامكم، ونتمنى أن تكون محاور هذا اليوم قد أسهمت في توسيع الفهم ودعم الممارسات المهنية. نلتقي غداً في تمام الساعة 10 صباحاً بمشيئة الله، لنتناول موضوعات عملية وقضايا تمس رحلة الطفل والتشخيص والتدخل المبكر. والسلام عليكم ورحمة الله وبركاته.